Good afternoon, everyone, and welcome to the Orange County School Board's work session, which has been scheduled for today for the purpose of discussing School Board Policy EBBA, disease prevention and face coverings. I also want to take this opportunity to welcome the members of the Medical Advisory Committee who are attending today's work session in person. And we have two members that are attending virtually, and in a minute I'll call on Dr. Hsu, Chairman of the Medical Advisory Committee, to take a roll call on their attendance at this meeting. And I also want to just share with any members of the public who might be here, this is a work session, and at work sessions we don't take public comment. However, we will be taking public comment at future meetings. On June 17th, we have a rule development workshop scheduled where we will take public input. And then again, the school board is scheduled to take this issue up for potential action on July 13th. And again, at that time, we will take public comment. Our school board members are attending in person or telephonically, so let me take a quick roll call. We have Member Gallo, Member Lopez,
Good afternoon, Madam Chair.
Member Cobert, virtually.
Good afternoon, Chair.
Thank you. Vice Chair Gould. Vice Chair Gould is unable to attend at this time. She is attending a funeral, and she may be joining us later on. Member Felder.
I'm here, Chairman.
Thank you. Dr. Castrodano.
Good afternoon.
Member Byrd.
Good afternoon, Chair.
Thank you. And likewise, I'm in attendance. Dr. Hsu, can we take a quick roll call of the Medical Advisory Committee?
Sure.
Or Dr. Jenkins, whoever. Go ahead.
All right. Let's. We'll go and get the roll call started. Dr. Kadia. Dr. Muzinski.
Present.
Nurse Ravendal.
Okay. Can I, Dr. Hsu, I'm not sure if your mic's on.
It is on.
It is? Okay,
Yes,
thank you.
Is it?
Okay.
Are we good?
Yes.
Okay. Dr. Schwartz. Okay, Dr. Schwartz is not here. Dr. Nielsen.
Present.
Dr. Harris. Okay, Dr. Ajay. Dr. Rodriguez. Dr. Mansfield.
Present.
I'm missing someone off the list. There's someone else that I'm supposed to be asking. I don't have the list in front of me. I apologize.
That's okay. Sorry to put you on the spot.
So sorry. Dr. Ajay. And then Dr. Hsu, I'm here.
All right.
I believe that's
Thank you.
That's who I have. Thank you.
Thank you. To my fellow board members and anyone who will be speaking, let me just remind everybody, these microphones are real touchy, so speak close into them and don't do what I just did and turn when you're talking, because we often lose the sound. And with that, I want to ask in just a minute for you to join me in a moment of silence, and I invite you to join us in the Pledge of Allegiance. But before doing that, I want to just reflect on the importance of yesterday, Memorial Day. I hope that everyone here had an opportunity to reflect on the sacrifice that so many men and women have made over the years to make sure that we continue to enjoy the freedoms that I think sometimes here in this country we too often take for granted. It is such an important time, not only for those who have died in the years past, but especially for the families that are living today that have lost loved ones in the last several years. So I would ask that all of us, if we know someone who has lost a loved one in the call of duty, that we remember them, that we reach out to remind them that we care and we're still here. And as I noticed the county did yesterday, I think it's also to think of a number of other first responders, whether that be law enforcement, fire rescue, our doctors, our nurses, and our teachers that have been on the front line this year in the fight against COVID. I know it's not the same as dying in combat, but we have many heroes in this community and around the world, and it's time for us to remember and reflect on the sacrifice that they've made for the safety and welfare of all of us. Let's rise for a moment of silence. Now for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. All right, we will begin our meeting with Dr. Jenkins. Dr. Jenkins, you're recognized.
Thank you, Madam Chair, members of the board, members of Medical Advisory Committee. Today is our rule development workshop today is our work session. Yeah, I'm looking at the wrong slide, I apologize. Today is our work session for policy EBBA. Everyone is familiar, that is our policy that actually covers face coverings. It is called disease prevention and face coverings. In the workshop setting, it is a discussion among the board members. I want to be very clear that staff developed the first draft of a policy. This is the first opportunity the board has to discuss that draft with the esteemed members of the Medical Advisory Committee. I also want to stress the MAC has not been asked to render a formal recommendation, rather to be here for discussion, opinions, and questions and answers. Ideas and thoughts around this whole issue of face mask coverings. Again, I want to stress the MAC has not been asked to render a formal recommendation, rather to be engaged in the discussion. Also want to acknowledge Dr. Pino from the Florida Department of Health, who is on the line as well, who will be a part of that discussion. We will begin today with a presentation from our Deputy General Counsel regarding the history of how we have come to this point in time. After that presentation with the background of also the draft policy, then the board and the MAC and Dr. Pino will engage in discussions, questions, and answers. I want to be very clear as well, there is no decision being rendered by the board at this point. Rather, at the next opportunity of a rule development workshop on June 17th, the members of the public will also be allowed to comment on the draft policy. The board will hear that interaction, that public testimony, and then come to some conclusions, trying to land us on an eventual policy toward the end of July. Currently, we believe all of those timelines will get us to a decision, final board policy on face mask covering, face coverings by July 13th. If all goes as planned, if there have to be additional rule development workshops because of substantial changes, then it will push that date back some because of requirements for advertising actual policy and rule changing. At this point, we do believe we will meet the needs of any parents trying to make decisions on whether or not to send their children for face-to-face instruction, as that is toward the end of the month of July for Orange County Virtual School. With that, Madam Chair, we are ready for our Deputy General Counsel to walk us through the presentation.
And Mr. Palmerini, before you begin, let me just clarify in terms of how members that are on the line can participate. Dr. Jenkins, I know that Member Covert has a phone number for our General Counsel, and our General Counsel will cue her in just as if she were sitting here as a board member. I have in front of me a board that shows who's indicated they wanted to speak, and it gives me the order. I would like, when we open it up to general discussion, Dr. Hsu, what I'd like to do after we hear Mr. Palmerini's presentation is to first take some comments from Dr. Pino, and then I'll turn to you to take comments from the Medical Advisory Board. But when we get to a point of just back and forth, and then we'll hear from the school board, and then we get to back and forth discussion, I do want to know the board member, the MAC members that are on the line, Dr. Jenkins, how do you suggest that they indicate that they want to be cued in to speak?
Wired?
I have an idea, and that is if we could give them Ms. Enval's number, and if she could cue them in as if they're Member Gould, and she can keep track of which one, and I will go to her to find out which of the MAC committee members is cued in to speak after we hear initial comments. Does that make sense?
Yeah, I was actually going to offer my number. I'm happy to give
That,
them.
that's fine, whichever number. I wanted, while Mr. Palmerini is giving his presentation, to make sure that
We
somebody
got it.
reaches out to, I think we have 2 MAC members on the line,
Got it.
so that they know who to contact. Perfect. And if, again, if they can be queued in as Member Gould, then I'll know the order. And to Mr. Palmerini, I apologize, sir. Go ahead.
Thank you, Madam Chair. Thank you, Madam Superintendent, members of the board, and members of the Medical Advisory Committee. Just wanted to take you through the presentation today. What we're going to do is we're going to do an overview regarding emergency rulemaking and the rulemaking process, not for you all, but for the members of the general public that may be watching this, just so they know what the rules are. We're going to go over the tentative schedule. We're going to go over the history of policy EBBA. This was a policy that underwent substantial revisions through the beginning of last year, and we're just going to go briefly through that. We're going to discuss the proposed revisions in the draft policy that staff developed that the superintendent mentioned. We're going to talk about next steps, and then we will open it for questions and discussion. Most everything that school districts do and agencies do in Florida is done by rulemaking, and I think it's appropriate to actually define the rule here. We didn't do it on the slide, but I think it's appropriate for you all to hear it. A rule means each agency statement of general applicability that implements, interprets, or prescribes law or policy, or describes the procedure or practice requirements of an agency. And the rule is also defined in the statute that says the term also includes the amendment or repeal of a rule. So if you've adopted a rule by rulemaking, in order to amend it or repeal it, you have to go through the rulemaking process. Now, if you do, there's an emergency rulemaking provision in the statute. It says if an agency finds that an immediate danger to the public health, safety, or welfare requires emergency action, the agency may adopt any rule necessitated by the immediate danger. So back when we were doing this in the fall of 2020, we had a pandemic that was going out of control. We were having spikes in numbers, and we needed to immediately protect the health, safety, and welfare of our students and our employees, our visitors who came on our campus. So we adopted the first couple versions of the face mask policy by emergency rulemaking. But then we also went through the regular rulemaking process and adopted this policy through regular rulemaking as well. So what we do is when we adopt an emergency rule, the whole purpose for revising the rule covering policy to make the wearing of face coverings voluntary is based upon guidance from the state, including the state Surgeon General, who states, and this is directly from a public health advisory he put out on, I believe it was April 29th. Scientific studies show that COVID-19 vaccines prevent individuals from COVID-19, dramatically diminishing hospitalization and death caused by COVID-19, and protect both the vaccinated individuals and others against COVID-19 infection. And it says, and if in order to determine whether or not to do this by emergency rulemaking, i.e. to repeal this rule, if the data demonstrates that vaccine decreases dangers to the public health, safety, and welfare, then there's not an ability to state that absent the emergency rulemaking, the face covering requirement is causing an immediate threat to health, public health, safety, and welfare. Basically, if we're seeing decrease in transmission, we can't say that there is an immediate emergency to health, public health, safety, and welfare, and therefore we can't repeal the rule by emergency rulemaking. So Ms. Enval and I and every other lawyer in our office has looked at it, and we all agree that this is not something that we can do on an emergency basis to amend or repeal this rule. So we have to go through the normal rulemaking process. Now, other districts around us have gone through, and we've looked at some of the things that they're doing. Lake County, their superintendent did it by a letter. I don't think Lake County adopted it formally as a policy, but their superintendent said by letter, we're going to end the mask mandate after the end of our school year. Osceola County, I talked with their general counsel. They followed the county's ordinance with regard to face coverings. The school district's requirement to wear masks expired. Other counties around us, Volusia County is going through the rulemaking process itself. They're moving their mask wearing from mandatory to permissive. The Brevard County Public Schools on May 11th said we're going to make mask wearing optional at the end of the school year. So I believe the end of their school year was June 3rd. So after June 3rd, they're going to be optional. The Seminole County School Board, they actually went through the full formal rulemaking process. They had them vote on May 11th to say we're going to have a final vote on, I believe it's June 22nd, to repeal our mask mandate. So certain counties did it as just an operational procedure. Certain counties did it through rulemaking. This board did it through rulemaking. So if you do it through the rulemaking process, you have to repeal it through the rulemaking process as well. Our tentative schedule, today we're here at the work session to get discussion on the draft policy. Our rule development workshop is scheduled for June 17th, 2021. That is the date when public input will be taken on this policy. Board approval, July 13th, 2021. Again, public input will be available for this board and it will be required. And the effective date is no later than August 2nd, 2021. That date was chosen for a reason, and we will get to that a little bit later, but it has to do with some of the agreements we have with our bargaining units. All right, the purpose of this face covering policy, it says currently it requires all persons on OCPS property, absent of certain exceptions, to wear a face covering which covers their nose and mouth in order to stop the spread of COVID-19. The proposed revision to this policy include making the wearing of face coverings optional for the 2021-2022 school year. And now I just want to go through the history of the policy. And I know you all know this and it's ingrained into you, but I think for the public who is listening, I think this is a helpful exercise. So on June 24th, 2020, Mayor Demings of Orange County issued Executive Order 2025, which mandated the usage of face coverings throughout the county. So we went through an emergency rulemaking procedure on August the 11th. We adopted the initial version of policy EBBA through the emergency rulemaking process because clearly there was an immediate danger to public health, safety, and welfare. On August the 25th, this board met 2 weeks later and had another meeting, and we adopted emergency revisions to EBBA. We did things like creating a process for students to seek a medical exemption, and we remember the mask with the exhalation valves where the initial guidance was those could be worn, but then guidance subsequently came through that said no, those are no good, and they help spread the virus. So we did away with that. On September the 8th, we again revised the policy through the emergency rulemaking procedure. That time, we created basically an appeals process for students who didn't get an initial mask exemption determination that they were satisfied with. So we created an appeal process with that. We talked about periodic breaks and when those breaks can be taken and where those can be taken. And then on October the 13th, on sort of a parallel track, we went through the regular rulemaking process. And the regular rulemaking process requires that you have a rule development workshop within 28 days before you finally adopt the rule. We did that. So we adopted a final rule on October 13th. We made additions. A lot of additions, if you remember at that time, was for students performing, in plays, chorus, band. So those were the basic changes we made on October 13th. But we've had that final policy in place since October 13th. It's been in place, and this is what we've operated on the entire school year. All right, fast forward to March 29th. The legislature's in session. The very first bill that passed out of the legislature this year, this is Laws of Florida 2021-1, was Senate Bill 72. And this was signed by the governor on March 29th. And it established 76838, providing educational institutions, and we're clearly within the definition of statute, immunity from civil liability for a COVID-19 related claim. And what that statute says is, did we make a good faith effort to substantially comply with authoritative or controlling government-issued health standards or guidance at the time the cause of action accrued? So if we are relying upon authoritative or controlling government-issued health standards or guidance, and somebody gets sick with COVID, this law would make us immune from liability. So that was the purpose of the law. Fast forward to April 14th, the Commissioner of Education, Richard Corcoran, issued a memo to all district school superintendents. And it said a couple things. First, it says, the data shows that a district's face covering policies do not impact the spread of the virus. That was in the letter. And then it says that we ask that districts which are currently implementing a mandated face covering policy, that they revise their policy to be voluntary for the 2021-2022 school year. So that was guidance, or that was a memorandum from the Commissioner of Education, April the 14th. April 29th, again, the State Surgeon General, Scott Reifkus, issued a public health advisory that stated and I've read this to you, so due to widespread COVID vaccine availability, fully vaccinated individuals shall no longer be advised to wear face coverings or to avoid social and recreational gatherings. So fast forward a couple days later, May 3rd, the governor issued Executive Order 2021, and it says 2021 or 21-101, excuse me, I'm sorry, lots of numbers there. So that executive order speaks to county governments, speaks to municipalities. This board, of course, is not either one of those. This board is a district school board adopted under Article 9 of the Florida Constitution. So this executive order deals with municipalities and counties, and it deals with emergency adopted ordinances of municipalities and counties. So the executive order also said nothing herein prescribes a political subdivision of the state from enacting ordinances pursuant to the regular enactment procedures to protect health, safety, and welfare of its local population. That executive order is effective July 1, 2021. Executive Order 2102, it says this order eliminates or supersedes any existing emergency order or ordinance issued by a county or municipality that imposes restrictions or mandates upon businesses or individuals due to the COVID-19 emergency. But again, not applicable to school districts by its own terms. We get guidance, clarification from the Commissioner of Education that same day, May 3rd. And the Commissioner of Education, Jacob Oliva, issued the following clarifying guidance. Questions have arisen over the impacts of the executive orders, which are not effective until July 1, 2021, and EO 21-102, which is effective immediately. To clarify, EO 21-102 only impacts city and county governments and does not impact school districts and individual schools. Moreover, 21-101 and 21-102 only impacts restrictive COVID ordinances that are adopted through emergency enactment. Neither 21-101 or 21-102 impacts any school district's policies for the remainder of the 2020-2021 school year. So again, we have a face covering policy that was adopted through regular rulemaking. We did the first couple versions of it by emergency rulemaking, but our policy is adopted by regular rulemaking. And we are clearly not a city or county government under the Florida Constitution. We are a district school board under Article 9. So by the very terms of the executive orders, it didn't apply to us. Now, fast forward May 12, 2021, the CDC issues guidance regarding fully vaccinated and non-vaccinated persons. If you remember, this is the date where, you know, if you're fully vaccinated, you don't have to wear a mask outdoors. You don't need to wear it in most indoor settings. They did have some exceptions, like for public transit, but this was the executive order or the CDC guidance that says, if you've been vaccinated, then, you know, in most circumstances, you don't have to wear the mask. And this was also around the time where, if you remember correctly, we got the emergency use authorization for those persons between the ages of 12 and 17 to get the Pfizer vaccine. So a lot of stuff was happening in that 1 or 2 day period around May 12th. One final consideration that we need to bring up, and I wanted to raise this just so you all have the full range of decision-making points. We have a memorandum of understanding with the Orange County Classroom Teachers Association that runs through July 31, 2021. So what that memorandum of understanding says is that masks should be worn by students and employees. So when this memorandum of understanding was entered into, it was in March. So the CDC guidance regarding, you know, fully vaccinated persons being able to shed the mask, it hadn't been issued yet. However, do you want to say these memoranda of understanding are fully enforceable by the union to the extent that we were to, you know, withdraw the mask mandate before July 31, 2021? And so that's why when you see in this policy, the proposed effective date is no later than August 2nd, 2021. This is to ensure that we are not in any violation of a currently negotiated memorandum of understanding that we have with the union. And I know you all know this, but for members, the benefit of the members of the public, if there is a conflict between a school board policy and our negotiated collective bargaining agreement or memorandum of understanding, the collective bargaining agreement or memorandum of understanding would be the one that you would enforce, and the conflicting policy would not be enforced. That's policy, school board policy HN, and it's in Article 2 of our contract. So Now, on to the revisions of the policy.
Mr. Palmerini, hold just a minute. Member Gallo? I would prefer, go ahead and ask your question, but moving forward, I would prefer that we hold all questions until we're finished and then come back. But is it something you feel like you need clarification for right now? We'll take this question and then let's move on. And I'll wait. Okay, thank you. All right, thank you. Let's wait until after we've heard all comments. Thank you.
Now, because the writing is small, I'm putting these on. So,
Not because you're old.
yeah, that too. Thank you, Madam Chair. I appreciate that. So our face covering policy. Our current policy cites CDC and World Health Organization guidance on face coverings. It cites the emergency order requiring schools to open face-to-face for instruction in 2021. That's the emergency order from Commissioner Corcoran last July. I believe it was 6th of last year. So we're taking all of that language out, and the revised policy cites the guidance from the Commissioner and the State Surgeon General. And it also cites that we intend for this policy revision to meet the requirements of the new 768-38 in order to get the liability immunity for COVID-19 claims. So we are citing specifically to the Commissioner and to the State Surgeon General as the authoritative government authorities upon which we are relying. So we want to be able to point to that in case we ever do get sued for COVID-19 liability, that we're basing our policy on the Commissioner, the State Surgeon General, and we intend to rely upon that statute. Section 1 of the rule, it says face coverings are required unless certain exceptions are met. In our revision, face coverings will be permitted at the discretion of each student, employee, visitor, or vendor, but it will not be required. Section 1 also discusses CDC guidance and guidance from other government entities. We had no language like that in the existing policy. What this policy says, the revision states, is that the school board will allow the superintendent to implement more restrictive face covering requirements if the CDC or government entities issue such guidance. So say, for example, we get the CDC coming out and saying, hey, in any area where there's community transmission over a certain percentage, and God knows I'm not the medical expert, instead of calling an emergency meeting that would require at least 48 hours notice, if we think it's such an emergency, it would give the superintendent the authority to act immediately. And then we could call a meeting and not be worried about, okay, we have people coming to school for a couple days when we should be wearing masks and they're not. So that would be the purpose of this revision. Again, the effective date section is no later than August 2nd. That is before the school year starts for 2021-2022, but after the MOU with CTA expires on July 31st. And the rest of the current policy, we're repealing it. So as you will see, this policy goes from about 6 pages down to like 1 1/4. So those are the changes. Next steps. The rule development workshop again, June 17th. Let me try that again. June 17, 2021. There will be public comment because there'll be a rule development workshop. Final policy adoption will be July 13, 2021 at a school board meeting. Again, there will be public comment taken. If there's a second rule development workshop is needed, if there's substantial revisions to this proposed policy, that will be done on June 23rd, 2021. Again, there will be public comment. If there's final adoption, if we have to go through that second rulemaking process and we have to adopt the policy finally, that will be scheduled for July 20th, 2021. That will be a special school board meeting, and there will be public comment at that special school board meeting. Again, the effective date is no later than August 2nd, 2021 for the reasons previously discussed. And the OCPS enrollment deadline. The reason why we want to have these policies done is to allow folks who, if they want to have their student, if they're not comfortable with mask wearing being optional, we want to allow them to be able to register their child at Orange County Virtual School. And that enrollment deadline is July 30th, 2021. I will turn it back over to the superintendent for school board questions and discussions with Dr. Pino and the Medical Advisory Committee. Thank you, Madam Superintendent.
Thank you, Mr. Palmerini, for that presentation. Certainly need to acknowledge that Dr. Kadia is present in the chamber, and also we have confirmed online for Chair of MAC, Nielsen is present online. Dr. Nielsen is present online, as well as Dr. Mansfield, Dr. Ajay, and Dr. Schwartz. So wanted to clarify that for the record, and they have been instructed when there is a need to queue in that they may send a message to me as well. And we've also confirmed Dr. Pino is still online until 3 o'clock. I need a note for the MAC chair. Dr. Schwartz is online until 2 p.m. So we understand many folks have other obligations that might draw them away from this time. So thanks again to those that are in attendance as well as online. We will pause now for any questions and clarifications from board members or from the MAC, and then listen to your discussion. Madam Chair.
Thank you. I was going to indicate I was going to call on Dr. Pino first, but let me first start with any questions only regarding clarifications, no debate or discussion. Member Geller, you had a clarification question?
Sorry. So I just wanted to clarify that the Senate Bill 72 that went in effect, it went in effect upon signing, right? So we're currently no longer liable. Okay.
That's
I just want to
Yeah.
clarify that for those who may not know. And then on the MOU, so the MOU does not come before the board for approval. That's something that the district negotiates with the union and then signs. But yet an MOU that does not come before the board can trump board policy. Did I hear that correctly?
Yes, ma'am. So, okay, let me get into the guts of the contract.
Can I think it's an important point. I'm not sure that it's a debatable point at this point, and I don't want to take us too far off a track. I completely understand what you're getting at, and I think from a policy standpoint, this board needs to bring this back for a very thorough discussion. But again, I don't want to veer too, if you can explain very quickly, I don't want to veer too far from the subject at hand.
Very good. Thank you, Madam Chair. So
Okay.
in the contract, I think it's Article 2, Section J, and if I have that memorized, I don't know why. It is, the district is empowered by the contract itself to enter into memoranda of understanding during the term of the contract in order to clarify or make sure that there's further clarity on certain operational procedures. So we have a provision in the contract that does that. Normally, memorandum of understanding, especially like this, did also deal with operational issues. Obviously, operational issues are the purview of the superintendent and her staff, so that's generally not something that comes back to the board. But the contract itself explicitly allows the parties to enter into those memoranda of understanding within the term of the contract in order to clarify issues.
Thank you.
Yes, ma'am.
I'm sorry, and just for clarification,
Yeah.
Madam Chair,
Yes.
just for clarification, that MOU did not trump current board policy, just for clarification.
No, it didn't. The language you described
Right.
might indicate it could. It's a governance question. It's a very valid question. And Ms. Enval will bring this back. Dr. Jenkins, Ms. Enval will look at this and bring this back in front of the board. Absolutely. Let me go to Member Byrd. Again, these are for clarification questions only regarding the presentation. Go ahead.
Okay, Mr. Palmerini, can you tell us in a little more detail about what would happen if we were to make the effective date immediate when we pass it, as in regards to the MOU?
So what would happen is we have the MOU in place. If we were to reject it, there is a provision in labor law that says a school district can't repudiate a settlement agreement or memorandum of understanding that it enters into. What would happen is I would anticipate the union would file an unfair labor practice charge. The unfair labor practice charge would be heard. If we made it effective before the end of the MOU, I think it would be seen to be a repudiation. We would lose the case. The union would be awarded its attorney's fees and costs for doing so. We would have to post notices on our website saying, "Hi, we violated the law and we pledge not to do it again." That would be the process.
Okay,
Madam
thank you.
Chair, one more time
Uh,
for clarification.
Go ahead, Dr. Jenkins.
For clarification, so everyone understands, you also have the opportunity to talk to your union to see if they would concede that end date. I think it's 13 days before the end of July, by the time the board approved it. You could have negotiation with your union to see if they would concede the additional 2.5 weeks.
Thank you, Dr. Jenkins. I was just going to point out in the language in the contract, it does say, in the event the school board chooses to revise the policy, we would attempt to negotiate with the union accordingly. So it doesn't absolutely preclude us from going in a different direction. There's a negotiation process. And those of us who have been through these negotiation processes probably recognize that it might take us longer to negotiate than the time involved in running out the clock. So just food for thought, but it's a technicality. Let me take a question from Member Felder, and then we'll go to Dr. Pino. Member Felder.
Thank you, Chair. I think I do have some understanding, but and maybe we haven't gotten to this part yet, but I just want to make sure that the public, members of our constituency that are listening, that they really understand about this policy, and because we had so much controversy at the last school board meeting regarding the wearing of masks, and when you're heightened in emotion, you sometimes we don't think logically, because if we were laxed on it and not really trying to come up with policy and following rules, then if something happens, we're not going to be held liable, and I think that's important. And maybe we haven't gotten on this part yet, but my concern, we can't ask questions if you're vaccinated. We can't do that. So what about people teachers or other students or administration with compromising health issues, and they're there, but you can't ask that question, so you're going to be masked or unmasked? I'm very concerned about that, because I don't know, Mr. Pomeranian and the medical people here, many people don't even understand, even after you get the second vaccination, there's an incubation period, and some people don't understand that, and you could be liable. So as a school board, and I think we're doing the best that we can to make sure that our children and school staff are safe. I like what our medical field, medical people are doing, but I just want to make sure that we make members of our districts, help them to really understand what this means and how important it is to follow rules and policy. I just wanted to stress that, because
Okay.
that's the first thing that came to my mind.
So let me clarify. All that we're going to take right now are questions of Mr. Palmerini on anything that this board did not understand that he said. So I don't think any other questions for Mr. Palmerini, just so that we are all working from the same starting point. Okay, great. So let's take a minute to hear from Dr. Pino. Dr. Pino, let me take a minute just before calling on you to thank you for your partnership throughout the last year, and for all the guidance and advice that you have shared with us along the way. And so I'm not trying to put you on the spot, but I did want to give you an opportunity if you wanted to comment on this subject or anything Mr. Palmerini discussed before we go to Mac, and then open it up to general discussion. You recognize, sir?
Thank you, Chairwoman. No, I don't have any specific. Some of the conundrums that you are going to face are the same that we are facing with society right now. And in this honor system that we have decided to engage with for vaccinations and masks, it makes it difficult, and it makes some people nervous about not being able to, know who's vaccinated and who isn't. But again, that's protected information as well. So we are all facing the same challenges, and I would be ready to give you a general view where we are with the pandemic and with the vaccination, if you don't have any initial questions.
All right, thank you, Dr. Pino. Let me turn to Chairman Hsu. And before I acknowledge you for comments, Chairman, we greatly value the relationship that we have enjoyed with Dr. Pino, especially during the last year. But I also, and this board recognizes that that's part of Dr. Pino's job. It is not part of y'all's job to partner with us and to lend so much of your time and expertise to us. I think most of us have either listened to your meetings live or we've come back and listened to your meetings, and we've heard very, very, very thorough debate and discussion on all of these topics. And so on behalf of the whole board, I want to thank each and every one of you for the time and the expertise and the passion that you've put into this issue. And with that, Dr. Shu, you're recognized.
Thank you, Madam Chair. You know, I know that the board has some tough decisions to make. It's very hard to predict the future, obviously, as to what's going on. But we are very happy and encouraged to see that the overall number of cases have continued to go down, as well as you know, the hospital census. And so, you know, we recognize the importance that vaccination has played. In fact, that is the major factor that has driven down the cases. In an ideal situation, if we are able to get vaccination to a critical level, where enough students, enough teachers are able to get vaccinated, this discussion wouldn't be as necessary as it is right now. So we're hopeful to continue to be moving in that direction. We'll just have to wait and see. We do continue to work very closely, and we appreciate the ability to work with the board, with Superintendent Jenkins, with Dr. Pino as well, as we are working together to get this pandemic behind us. I don't have any specific, we're happy to take questions. If you would like, I would be happy to actually ask Dr. Musinski to say a few words as well, and maybe anyone else in here would like to just say a few opening statements. I would be happy to do that, if that's okay.
Let's do that. And then I think Dr. Pino offered to give us an update, and I think that would be a healthy thing for us to hear too before the board engages, our board to engages in discussion. Dr. Musinski.
Thank you, Chair Jacobs. And thank you, school board, and thank you, superintendent, and thanks to my fellow committee members for working so carefully on this topic of vital importance for our schools and our children. Just for like a background and maybe laying a foundation for understanding of everyone, including those in the public who are currently listening to this, I'd like to go from the State Surgeon General's comment and then come down to the Commissioner Corcoran's statement requesting that we make masks voluntary in schools and almost mandate it at that point. Mandate that at this point. As you heard, Dr. Rivkes said due to COVID-19 widespread vaccine availability, fully vaccinated individuals should no longer be advised to wear face coverings or avoid social and recreational gathering except in limited circumstances. You have to understand that he said the words fully vaccinated. He didn't make any comments about the unvaccinated. Then we get down to Commissioner Corcoran's statement that says that we should go ahead and just make masks no longer mandated. And I think no longer mandating masks is the goal that we want to reach. There's no doubt about it. Every pediatrician on this commission is stressing that we would like to see children looking at each other's faces rather than face masks. Well, there is also much to know in between those two statements with ending mask mandate as a goal, a true goal, and an important goal. There's no doubt that COVID risk is greatly decreasing and will continue to decrease in dramatic fashion due to the incredible effectiveness of the vaccines. So we're now closing in on what's called herd immunity, and a lot of you have heard that term, but what is it exactly? I'll explain it really as simply as I can. Herd immunity is when enough people are immune to the virus that the virus has no place to go. The virus tries to go to someone and hops into them, and they're immune, and the virus dies, and it tries somebody else and dies, it dies. So there's no more super spreading events when a significant proportion of the community is vaccinated, and the number of people one infected COVID person could infect themselves goes way down to almost zero. So then the pandemic ends when you get there. So what happened? Where are we now? Where is the virus finding it easy to go to infect someone in the United States today? What group of the population is it? It's the unvaccinated. Now, my age, greater than 65 years of age, 88 to 90+%, depending on what county you're looking at in Florida, of us are vaccinated. So we baby boomers really went after the vaccine because we didn't want to get sick and be in the hospital on a ventilator because our risk was the highest. And now the risk group is under 18 years old for a while. And it turns out that recently the vaccine, as you know, was approved on an emergency basis by the FDA for 12 to 18 years of age. And now 12 to 18-year-olds are starting to get vaccinated. But they remain in a higher risk group because they're mainly unvaccinated at this point. And there's no vaccine yet for any child under the age of 12 yet. So the vulnerable in our population has shifted to all vaccinated, unvaccinated people. And also those, even if they're vaccinated, who have immune problems where they can't properly react to the vaccine. Those are people with cancer, organ transplants, bone marrow transplants, and other immune deficiencies. In the worst of COVID, in 2020, you have to understand what was going on with children, defined as less than 18 years of age. They made up about 5 to 7% of all COVID cases in the worst of it, when we were seeing 3,000 to nearly 4,000 deaths a day at one point from this disease. They only made up a really tiny proportion. So everyone said kids are safe, you know, because they just really don't get this disease. Well, with the shift now in vaccination, we have so many protected people who are older. The virus says, I don't know where I'll go. I'll find somebody who's not vaccinated, and that's our kids. So now the American Academy of Pediatrics recently announced its data that shows that at least 24% and climbing of all children make up COVID now. That's a dramatic increase from 5%. And they point out that 10 to 17%, depending on which study you look at, 10 to 17% of those infected children end up in the hospital. So having looked at all this data very carefully on my own accord, I would conclude for you at this point in time that we can permit masks to still be used with guidance to parents, staff, visitors, and vendors who are unvaccinated, to have them strongly consider wearing a mask to protect themselves because they're the ones in danger. And not only the unvaccinated, but those who have immune systems issues. So all in all, the burden of COVID is shifted to the unvaccinated, and unfortunately children under 12 are in that group right now. That will soon improve by the end of the year at least, or maybe even just as the fall gets started, when the FDA will likely approve the COVID vaccine down to 2 years of age, which will be a great achievement for us as a country. The other thing I want to say is that without guidance for those who choose not to wear a mask, who are unvaccinated or have immune issues, we may be shirking our duty as a committee to not inform them in some fashion that they're at risk. And that risk is not small, it's significant, and they should take that into account. Now, in the political atmosphere of 2021, things are kind of hairy. You wear a mask in a school where it's voluntary to wear a mask if you're unvaccinated or have an immune problem. You're basically wearing a red badge saying, I am unvaccinated, I have an immune problem, and people aren't going to go for that. So that is the difficult political and social nature of any recommendation in that direction, or any policy in that direction, I should say. But all in all, I see COVID dropping to rates, percentage rates, I'm sure we could hear from Dr. Pino. They are now where, if they were that back in August of last year or any time last year, we would say relax mandates way back then. And they've now reached that point statewide. So this is an exciting development. I am optimistic for the future, but we just have to make sure people understand their risks if they don't get the vaccine or they have immune problems. And I thank you for giving me this opportunity to lay the groundwork.
Thank you, Dr. Muszynski. Chairman Shu, any other members of MAC that want to comment before we, thank you.
Dr.
We
Nielsen would
have
actually- Yeah.
Dr. Nielsen on the line to make comments. Dr. Nielsen, you're recognized.
Hi, thank you, Madam Chair. I have just a couple points. I completely respect Dr. Musinski. I think he made some excellent points. I think you have to look at what's available right now. So 12-year-olds and up can get the Pfizer vaccine. They can make a choice. Their parents can choose. Same with teachers and staff. They have the ability to make an informed choice. So they can choose to protect themselves with a vaccine or not. And so, in my opinion, I feel it's reasonable to say that those individuals have the ability and potentially informed ability to make a decision on if they want to wear a mask or not. When you look at your younger kids, your 3-year-olds to your 11 and nearly 12-year-olds, they don't have an option. They don't have an option to be protected from a vaccine. We, however, have an option, and I believe a duty to keep that subset, that group, protected. I feel that that group should wear a mask until we have the ability for that group to actually have a vaccine option. I feel we're doing them a disservice and we're discounting their voice and their medical fragileness. We know that high school kids tended to spread it more, but our elementary scale kids do too. And like Dr. Musinski mentioned, 10 to 17% of those infected are ending up in a hospital. Well, it's those kids because they have smaller lungs and smaller blood vessels, it seems. Our policy, it wasn't an emergency order. It was a very well thought out and success of a policy. It's one that I think other counties look at and go, wow, y'all did a great job, because you did. You made wise, conscious choices and decisions. The CDC this morning came out with new recommendations on masks and camp attendance, and it included that kids that are vaccinated, again, shouldn't have to wear a mask. And if you're outdoors, you shouldn't have to wear one, I believe. And so I think doing something like that, saying, okay, if kids are outside, PE, exercise, doing things outside, even in the elementary school, I would feel comfortable with them not wearing a mask. But I do feel like in an elementary school, during the day in a classroom, until they're able to get a vaccine, I feel you have a duty to protect them a little bit more, because those children don't have the ability to make an informed decision. Neither do their parents. So I guess I feel strongly that elementary kids still need to wear a mask during the day. Take it off when they're outside, but during the day, let's keep them protected.
Thank you, Dr. Nielsen. Any other comments from medical advisory? Dr. Kadia, you're recognized.
Thank you for the opportunity, and I think that this talk is a little different. Like you said, you've listened to us a year ago. I think the talk was very different, so I'm glad that we're at this point. I'd like to just reinforce what I believe a lot of people here have been saying is the vaccines work. They're not meant to stop you from getting ill 100% of the time, but they're supposed to keep you out of the hospital or keep you from dying most of the time, and that's what they're doing. Unfortunately, those under 12 don't have that choice yet, and that is a large proportion of our kids. It is really nice to see that as of last week, 76,000 plus children between the ages of 12 and 14 were vaccinated in Florida. In Orange County, it's about 7,800 children between 12 and 14 years of age. So they are getting it. I can't wait for everyone to have that availability. A few points would be, just as Dr. Nielsen pointed out, that the CDC guidance on summer camps. If you have children or if you have persons who are unvaccinated, you're still going to be advised to wear masks all the time. There are some exceptions with overnight camps. Also, the commissioner, when the email came out or the letter stating that there was data to suggest that masks are not useful in a school setting, I actually want to see that data. I am looking at an MMWR looking at Florida schools from August to December, and it clearly found that there was success in preventing school transmission when you adhere to mitigation measures. And one of the things that was helpful was wearing masks. Districts that had policy mandates for mask use had a lower rate of infection of SARS-CoV-2 in children, again, in Florida. Lastly, I'd like to point out an MMWR published last week looking at mitigation efforts, masks, and ventilation in Georgia. It was helpful. Now, they do point out that this data was looked at prior to the vaccines coming out. And they point out that since the completion of the study, COVID-19 vaccines have become widely available, and the CDC recommends vaccination for teachers, staff, and members, and students ages 12 and over. Until vaccines are available for children ages 12 and under, universal and correct mask use is a critical prevention strategy that the CDC recommends that schools prioritize regardless of vaccination status for in-person learning. I see this as references to be used in support of their updated guidance that we could expect in upcoming weeks for reopening schools in the fall. And so in all, I do agree that mask use will be helpful, especially in that population of children that haven't had the opportunity to be vaccinated yet. Thank you. And I will answer questions later, right?
Thank you, Dr. Katia. Any other comments?
Darcy, please.
Is this on? Okay. It's indisputable that wearing masks, particularly in our under 12 population, is very important, and it's going to play a huge role moving forward because we don't have a vaccine available for them. However, coming from less of a medical and scientific background and looking at it from a public health perspective, I think we can create, and I don't necessarily mean we, I just mean kind of in general, we can create the best rules, the most thoughtful, scientifically sound rules, but if they are not able to be implemented, they're really not worth much. Again, kind of looking at it from,
Thank you. On the ground, kind of boots on the ground situation, even in those last 2 weeks of May, that we're kind of still in here with the schools. As soon as a lot of these things from Commissioner Corcoran and others from Governor DeSantis came down and said, oh, here are some new things. Well, the CDC said, and again, we're hearing from so many people, and parents and families and students are hearing from so many sources of information, whether they're good, bad, or in between. But it's very hard in a school to implement rules and have them be consistent, and it can create a lot of problems. And I just think it's something to discuss as you're kind of coming up with this, that as long, a rule is very good, but it has to be usable in the field, in the schools. And that's tough. I mean, you can talk to anyone in a front office and just, I'm sure you've all heard this, how many times, well, the CDC now says I don't have to do this, or, so-and-so says that. It's a real thing, and it's a major challenge if, students are home and they're not wearing masks and their families are not wearing masks. It's really hard, I think. Last fall, it wasn't hard because we were in a major crisis, and we still are. But it is a different crisis at this point, and I think that implementation is just something that needs to be considered.
Thank you. Thank you, Nurse Practitioner Randall. Anybody else? All right, let's, Member Gallo, we're going to hear from Dr. Pino? Or we're going to hear from Dr. Pino, and then we'll go to you. Thank you. Dr. Pino, if you're still online with us, you offered to give us an update. Perhaps we should have started that with Mr. Palmerini, but.
Can you hear me?
Yes, sir.
Okay, good. So, yes, let me give you an update in a few things. First, we got additional resources from the state. It's about $32 million. That will be, we are in the initial planning phases, and we'll consult with the superintendent and others from the school. But that money is intended for the new school year to do surveillance and testing in the schools. So that is to say that we are planning to prepare for the reopening of the schools as many of the students from 12 and younger have not been vaccinated or haven't had the chance to be vaccinated if they choose to. So we are going to prepare to the degree that we can, to contain any future outbreaks that may happen in the schools when we fully reopen in the near future. So more to come on that. We got that money, or the announcement of that money last week, and we have quickly engaged into developing a plan on how to address this issue. But of course, we will always consult with the superintendent and her team on how to proceed, but we are in the initial stages of budgeting and developing that strategy. Any question on that?
Any questions on that? No? Go ahead, Dr. Pino.
Okay, with regard to the pandemic, we are in a very, very good position, as some of the members of the board and some of the members, the clinical members of the board and the advisory board have mentioned before. So since May 22nd, we have been below 5% in positive rate rolling average. And if it continues to be this way, which is no indication that it shouldn't be that way, probably by Saturday, this coming week, we could be in what the mayor have described a third phase, which may not require or advise anyone, everyone can go basically unmasked when it gets to phase 3. So with regard to the pandemic, it's quite interesting things happening. Some of you, mentioning the fact that as older people get vaccinated, we are pushing kind of pandemic into those who have not been able to get vaccinated. And just to give you an idea, our highest positive rate by age group is in the group of 5 to 14 years old, have the highest positive rate of those labs that have been provided to the states the results. With regard to the pandemic itself, our numbers continue to be very, very low. Yesterday, for example, only 77 people were diagnosed with the disease that have been reported to us. And that continued to be the case. It's a long time since we have been below 100 cases a day. So that is good to see. And also has been a dramatic reduction of death rate and hospitalization, especially among people who live in assisted living facility. That was one of the first places that we engage in immunizing. But I agree with members of the panel and the board that we have a lot of work to do for people who are younger than 12, but also for people who are younger than 18. With that, we have only vaccinated in the county residents under 18, only about 30,195. And that's a very low number for a population that we consider to be in the 100,000, probably close to 200,000. And that is a low number for what we can see in the data. And only for people younger than 18, only 8,000 people, 8,007 to be correct, have been fully vaccinated. Our population, it really needs a boost in people who are younger than 18. Just to give you an idea, our population between 15 and 17, and that's the one that we have calculated right now, is 51,004. And so we still have a lot of work to do. With regard to immunizations, the county has given 1,172,841 shots, injections in our county since December 26th. For vaccination rates, I'm going to give you several age groups, and that percentage that I'm going to give you, it is a specific group. So if I say people over 75, this is a percentage, it doesn't mean the entire population, only people over 75. So with that, people over 65 that have received at least one dose, we are about 85.45%. So we have done significant progress there. Now, when you move that group to over 18, then the percentage comes to 48.33. But to the data that we are tracking is for 16 and older, and that's based on the mayor's ordinance. And people 16 and older who have received at least one dose, we are at 54.64%, with about 640,000 doses to that age group. We have our strategy right now is we are trying to increase vaccinations in the schools with the contractors that successfully the board has worked with, and they have been so successful. But we are trying to bring the vaccine closer to our community, closer to individuals, so that we take any barriers off the table and people can have access to a much needed vaccine. But there is no doubt that we still have some work to do, especially in the Jorgen semi of the population. Thanks.
Thank you, Dr. Pino. Dr. Pino, I have a question for you. So we hear the statistic that 25% that our young people are making up a higher percent, from 5% at one point to 25% of the positive rates. I'm assuming that when I'm hearing that, we're keeping the denominator as the total tested population. And so when I hear that increase, I'm not sure if that's because the denominator has gone down and the numerator, being the number of young people that test positive, has remained the same, or whether the number of young people below 18 has gone up. And so I don't think you can probably answer that question, but you were telling us that your highest positive rate is coming with children between the age of 5 to 14. Can you tell us what that positive rate is when you use the total number of children between 5 and 14 as the denominator and the positive as the numerator? In other words, looking at that cohort, what is the positive rate?
Oh, but the positive rate, the way that we calculate it, only takes into consideration the number of people that were tested that day.
No,
on
absolutely.
that age group.
But the number of people tested between 5 and 14 relative to the number of positive tests in that same age group, what is that running at?
I will have to calculate that.
Okay.
Yeah.
Dr. Kadia, you have an answer for that?
So not specifically for Florida, but the American Academy of Pediatrics does have updates every once in a while, and the latest one was about 2 weeks ago. So out of 11 states reporting, children made up anywhere between 6 and 20% of total tests, and anywhere between 5 and 35% tested positive. So it really varies across the nation, but just so you get an idea.
Okay. Thank you. All right, thank you. Any other questions for Dr. Pino and Dr. Muszynski? A question or an answer, and then I'll go to Member Gallo.
I have an answer.
Okay.
Sort of, my answer. And a question for Dr. Pino, actually. My answer is that, Chair Jacobs, when you look at the disease, it's a big pie of everybody who has COVID, anybody who has COVID. And that's what the virus is seeing. It's seeing the whole population, and the virus is trying to move within that population. It's not picking out little segments of it. It's looking for someone who's vulnerable. And so what it turns out, chunk of that pie is what Dr. Kadia says, anywhere from up to 24% of the current total pie on the middle of those numbers that you gave are children under 18, and that's just a fact. Before it was like everybody was old, like me, and because we got tested more often too. That's another problem with the denominator. So the question I had for Dr. Pino, actually I have two, Dr. Pino, if you don't mind. One's a technical question for an ID geek like me. Do you know the case rate per 100,000 population for the county? That's my first question. My second one is, are you using any mobile units to get the vaccine out? Those are my two questions. Thanks.
Yes, the second question, yes, we have a mobile unit that is going around. The county has in their website a map, a geo map, that you can click on it. You will see where the mobile unit was and where the mobile unit is going to be that day so that people can have access to it. But if you want to see it, it's every Wednesday in the morning on Eola Park. That's a fixed location there that we have tried to have access to people who are experiencing homelessness. I don't have the rate right now per 100,000 in front of me, but I will ask it to be calculated.
Okay, I'm going to go to Member Gallo in just a second. I do want to just close the loop on the comment that I just made, unless there's so there's not confusion. I appreciate very much the feedback about under 12, the vaccine availability, and I am honestly right now very much of a sponge, taking in and still listening and processing. We have time before we make a decision, and things can change between now and the time we make a decision. But at the same time, when I hear that children under the age of 18 have gone from 5 to 25% of the population, that on the surface sounds like there's they've increased 5 times the number of children. But in fact, it may be that the total number of adults has come down so much, the number of children may have stayed the same. It just makes up the same percent or the same amount of a smaller pie, therefore it looks like a bigger number. I'm honestly trying to understand where those numbers come from, to understand whether we really have an increase in children, which could be happening because, as you point out, the virus is looking for some place to go, and more adults are no longer a good host. Or I think more likely, as less adults have it, the number appears to be larger because the denominator is shrinking. I suspect it's maybe a combination, but I do want to make sure that whatever decisions we make it on full understanding of the facts of where we are. And with that, let me turn it to Member Gallo.
Thank you, Madam Chair. And I agree with your assertions. I'm glad that you made it, because I think that you're right. I think that the pot's shrinking, so that number's growing. My question is basically extremely simple, and I guess I could ask it to Dr. Pino or to the panel. What is the effectiveness to the person wearing the mask? We're hearing stories that in order for the virus to be contained, we have to have universal mask wearing. But for those who haven't been vaccinated, what is the effectiveness to just the person wearing a mask on contamination?
Who would like to answer that?
Yeah, I can take part of that. Anyone else? So first, I got to the rate for 100,000 for people between 15 and 17 years of age. That rate is 40.7 right now. The highest we have was 336, and that was at the beginning of the year. And since then, it has been in a constant decline. Now, with regard to the mask, so any barrier really that interferes with the ability of the droplets and the virus to leave from individual to another is a good thing. There has been several studies. There is one out of UCF that it looks very nicely into how the masks work and what distance, what type of mask, and they did it under different circumstances, and the conclusions are very clear. But also it's somewhat, because we have focused so much on COVID, and COVID is so infectious. But if someone really wants to look at how effective the mask is, ask yourself where flu is this season, because we have basically seen no flu this season compared to any other that we have record of. And it is clearly the mask has made also an impact on flu transmission, besides, hygiene measures and washing your hands and keeping you decent. But it's a whole package about limiting the ability of the virus to jump from individual to individual.
But
Member
my
Gallo,
question
follow-up?
is it just effective if just
Yeah,
one person's wearing the mask and not everybody? So say if I'm immune compromised and masks are not mandatory, they're optional, and I'm a parent that's worried about my child's health. How comfortable as a parent can I be sending my kid to school with a mask on? How, what is the percentage of safety that this mask offers that student so that they could safely go to school?
Can we add to that? Just, so there's two components. There's, if I'm infected and I have a mask, how much protection am I giving to others by wearing the mask? And how much protection are you getting by wearing the mask if you're worried and vulnerable and not infected? So I forget exactly
Yeah,
the
I'll-
terminology. Dr. Shu.
No,
Sure.
that's great. It's really hard to pinpoint an absolute number. When they do studies in the laboratory, depending upon the type of mask type of the fabric that's being used, it could prevent transmission by 30 to 70%. I mean, that's just, I know it's kind of right in the middle. When you look at real world studies that occur, there are times in which there were events in which everyone wore a mask and there was no transmission, even though there was someone with COVID. I mean, that effectively is 100%, although we recognize it's not 100%, all the time. So it really varies as to whether or not, as to the protection of the person who's wearing it versus the one who's infected who wears the mask. There are two types of protection. One is, yes, to protect what we call source control. Basically, the person that may have the virus, because they're wearing the mask, the virus is much more apt to just stay confined and not travel large distances. We believe that to be probably the more effective way to reduce transmission. But there's also benefits to the wearer who's not infected that might have exposure to someone who has the COVID virus. In those cases, a well-fitting mask is really important. So, there's been talked about double mask or tightness because, again, that seal makes a difference. I mean, the ultimate test of a well-fitted mask is what we call the N95 that healthcare workers wear. I mean, that one just, causes a complete seal, blocks out 95% of all infectious particles. So there are benefits to both, for both the wearer as well as the wearer who's non-infected, as well as to the person who's infected. Again, I cannot quantitate an exact number, but masks do work, and there's plenty of data looking in that area that support the effectiveness of masks.
So a child that's wearing a mask would be protected if no one else around them were wearing a mask.
There would be some effectiveness, yes, absolutely.
Dr. Musinski.
I agree with everything Dr. Shu said. To your question, the individual student who's wearing a mask and nobody else is, considering that someone else is infectious, will be protected, but to a degree of somewhere between 50 or 70% chance of reduction of the chance of getting COVID from someone who's in their 6-foot vicinity. The other thing that you can't really measure very well is it's a coughing child, a screaming, crying child, or anybody who's forcing air out of their mouths without a mask on is much more likely to spread virus around in the local vicinity in large amounts that someone can catch it. But I can tell you this for sure. There's no doubt about this fact. Ready? Maybe your chances of stopping the virus, if you're wearing a mask the virus is coming at you, approaches 70% in some cases, depending on mask type, as we heard. But your chances of your protection without the mask, with someone infected in front of you without a mask, is 0. So you got to take that into consideration. So who wouldn't, in their right mind, if I told you your chance of dying in automobile crashes if you do the simple change to your car, would be decreased by 70%, who in their right mind wouldn't make that change? And that's the rationale behind this. And so masks do protect. The supposed articles that say that they don't twist the data and look at it in weird ways and actually contradict the data. So there's no credence whatsoever to that notion that they have absolutely no protection. If you watch the physics laboratory simulations of respiratory droplets, which small, tiny, or aerosol is what COVID rides on. It's not a single virus coming out. It's in liquid material coming out of your nose and mouth. As Dr. Shu pointed out, without it, and if you're talking as loud as I am right now, it's going to be shooting out about 4 feet away from me where it can infect somebody. But I put a mask on, it's falling within less than a foot, probably 6 inches, if it's coming out at all, from my mask and dropping straight down. And that's why the distancing helps to work in the formula too. This is stuff that's been shown in the laboratory over and over and over again. As Dr. Shu pointed out, in population epidemiologic studies, places where people were wearing masks and weren't wearing masks, there's a major difference in transmission in those scenarios. And then lastly, Dr. Pino mentioned, where did influenza go? That's a good question. Influenza went the way of masks and distancing. That's where it went. That's why a lot of countries wear masks during influenza season. A lot of people do in other countries because they don't want to get the flu, despite the fact they got the vaccine. Then number two, I don't think anybody recognized, I know Dr. Kadia does because she's a peds person like me in infectious disease, but other major viruses that send our kids to hospital and intensive care units, like respiratory syncytial virus, parainfluenzas, adenovirus, they're gone. They didn't happen this year, as flat as could be. And now with relaxing all these mask mandates, you watch, they're going to come back with a vengeance. So that is just more proof in the pudding that these masks work for not just COVID, they work for any respiratory virus. So if you want to go to your next cocktail party and be totally safe and not get adenovirus from somebody, instead of COVID, wear a mask and look like a fool. But anyways, that's basically my answer for your question.
Thank you, Dr.
Hopefully it was
Musinski.
useful.
Absolutely. Member Gallo?
I
Anything?
have more questions, but I'm gonna.
Okay,
I
all
want
right,
to
let me
my
go to
fellow board members.
Member Castellano. Thank you, and we'll come back around. Member Castellano?
Thank you, Madam Chair. I'm going to pull up my questions again. And first, before I ask my questions, I just want to thank all members of the Medical Advisory Committee for all your time and guidance and expertise. We could not have gotten through this school year without it. And I know that your efforts have saved lives. So I appreciate all that you are giving to our district. We get emails. We all get emails from different parents and constituents. And I just want to see if I can have you address some of the things that they're saying. First is, they say that sometimes that cloth masks are harmful to those who wear them, whether they're breathing in their own carbon dioxide or they're not getting enough breath or oxygen. Is there someone that could address that statement?
You want to, yeah, we're holding our head.
That is a myth.
The simple answer is it's nonsense. But the more important answer is to try to reason and show what the actual facts are. We know that your oxygen content does not go down in breathing through a cloth mask or even an N95 for all that matter, which is the tightest fitting one there is. Your oxygen levels, I think if your oxygen levels are dropping to dangerous levels like we're told by these emails, then our surgeons who are in operating rooms 8 hours a day, especially a heart transplant surgeon, should be dropping like flies all over the place, but they're not, they're fine. And so that's kind of nonsense. There are some severe pulmonary conditions where the person can't walk 5 steps because of their lung disease, that it might impair breathing in that situation. But other than that, there's really no medical reason not to wear a mask, except in pediatrics, because there are children who are mask adverse because they have challenges that need to be addressed in a developmental way. So that's the caveat to that. The fact that you're breathing in your own germs, I mean, take your mask off, you're breathing in your own germs. You're breathing in your own germs at a concentrated amount. Well, those germs aren't harming you now. What would make them harm you? It doesn't make any sense. It's just things that people just are grabbing at in order to make an excuse not to wear a mask when it was really important to wear one. The other thing you mentioned was carbon dioxide levels. It does not increase carbon dioxide levels. That you can't breathe when you wear a mask. That has some credence for people who are claustrophobic. That can cause a panic attack in someone with claustrophobia, which would be kind of rare, but it happens. Then the reason why you feel like you can't breathe is very interesting. It is a feeling, but it's not that you can't breathe. Oh, what's going on there?
I'm sorry, Dr. Musinski, if you could hold just a minute. Victor, I hope you're able to hear me. Can you silence whatever phone line that is that we're hearing? All right, that sounds optimistic. Dr. Musinski, I apologize for that interruption.
That's okay. Let me get back when you put a mask on today, come here, you kind of feel like you're constricted, and I don't feel like I can breathe. Like I'm not getting enough air, right? You feel that way, right? And there's a reason why. A really very clear reason why. Your nasal passages and your respiratory lining have nerve receptors that are very, very sensitive to temperature. And when you breathe in, it cools, the movement of the air cools the lining of your respiratory tract. And then these little sensors on these nerves send a message to your brain, said, everything's okay, you're breathing. Okay? When suddenly it gets really warm, if you're in a hot room or a sauna and you're breathing in hot air, you feel like you can't breathe in the sauna, but you're fine. Your oxygen levels are normal, your carbon dioxide levels are normal, you just can't feel like you're breathing. And then there's a trick that some companies use for medical stuff in some nefarious ways in cigarettes, where you put menthol or eucalyptus or one of those things on yourself, a rub, and those vapors are set off those little sensors saying, hey, things are cool in here, so you think you're breathing better, when really, if you were having trouble breathing, you're not breathing better, you just feel like it. So the point is, you feel yucky, but after a while you get used to it and nothing really adverse happens to you. And this has been studied over and over again because, gee, we don't want to kill our surgeons, do we?
Right. Thank you for that explanation. I haven't really heard that much detail.
I'm just going to echo what Dr. Musinski said and add to it that I use the surgeon analogy often as well, right? You don't want a surgeon who's going to drop dead because they're not breathing to be operating on you. But it's everyone in the staff in the hospital right now, the COVID units, and they weren't just wearing these kinds of masks, they're wearing the N95s and the shields and the yellow gowns and the gloves, and they're doing okay. Also, in the construction industry, they wear respirators as well. Painters do. A lot of people wear them for their jobs to protect them, and they do well. So I just urge the community to not just hear something on the internet and believe it. Do your research and look it up and just find the truth behind all those questions and ask them and listen to the answers as well.
Thank you.
Anything else?
Yeah.
Dr. Castellano?
Well, that reminds, oh wait.
Dr. Jenkins?
I'm sorry, Dr. Ajay is in queue. He's on the line. He queued us.
Okay.
I think it's the same question that
Okay.
Member Casterdental had.
I'll come to him in just a minute. Dr. Casterdental? Thank you. Dr. Casterdental, you want to finish?
I didn't know if he wanted to answer that same question.
Oh, okay. Perfect. Thank you. Dr. Ajay, you're recognized. Dr. Ajay, if you can hear me, you're recognized. This would probably be a good time to say unmute in case you're muted, maybe. All right, Dr. Ajay, we're going to come back to you in just a minute.
Okay.
Member Casterdental, let's go on to the next question.
Okay, well, this kind of transitions to what Dr. Kadia just said, that some citizens are skeptical of the CDC and their guidance, and as a result, they actively thwart their recommendations. Like what Nurse Ravindal was talking about, it's very difficult sometimes for the people in our schools to follow our rules when they don't believe the guidance that they're based on. So in your opinion, whoever wants to answer this, do you find any reason to doubt the CDC's guidance? And are there other organizations or schools of public health that can be a reliable resource for the public if they don't want to listen to the CDC? Dr. Sue?
Thank you, Member Castor-Dental. Having worked at the CDC, I worked there for 3 years. I have full confidence in the data that they present. There's no doubt that the CDC has made some missteps. The examples were very, very slow to be testing during the early parts of the pandemic. There were probably other areas that they probably wish they, could have taken back perhaps. But as to the recommendations and as far as the science is concerned, I have full confidence that what they have put out on their website, and at least the data that they have are absolutely, that they take all the data and they look at that and they pretty much are in agreement with what they put out on there. The difficulty I think the CDC has is that they're in a very tough situation. There are areas in which operationalizing isn't really working very well. To say, for example, few weeks ago that vaccinated people can do this, but you can't do that for unvaccinated person makes it very difficult because there isn't a system in place to be able to monitor that. And yet the CDC recognizes also that we in the American public are wanting to move forward. There is a need to move forward, but there isn't all the data out there. So for those reasons, the CDC always wants to be a little more cautious, and yet they're also in the hot seat if they don't move fast enough, with these issues. But as far as the integrity of the data are concerned, I have full confidence that the data are there. It's just how do you apply that? And also the other issue is that the CDC has to make general broad recommendations for the entire United States. Where there are pockets of infections that are worse in other areas, there, in Hawaii, for example, where cases have been low because they're an island nation, they could have probably moved at a quicker pace than other places. So the difficulty that the CDC has with its credibility is not with the science itself, but perhaps not being able to act on how do you operationalize that science, the fact that there are pockets of infections here and there that it can't be easily generalizable, and perhaps even lack of data in some areas. So that would be the areas that I would say we need to continue to work on, and every jurisdiction, and every business has to make decisions on their own that are not being addressed by CDC.
Dr. Jai?
If I can add to that, this is Dr. Rolfino. Also, let's keep in mind the CDC can only recommend advice. They can't do mandates. They don't have empower. They can't force their recommendations. They don't have legal instruments to do so. But also to the point that Dr. Shu was making, everyone in the world, even in the universities, even all the CDC centers, follow the CDC guidance in Atlanta. So it's going to be difficult to recommend anyone else to be followed when this is the most prominent public health institution that we have in the world. Now, it works best when politics out of the mix, and that's a little bit difficult in our country right now. But the CDC can be trusted, and their knowledge base is just immense, and all the decisions are driven by data. And that what is important is to look at the data, how it's showing, how is the pandemic moving along. Thanks.
Thank you, Dr. Pino. Dr. Jai?
Okay, so I was a couple of things. Hopefully you can hear me now.
Yes, sir, we can.
First things first is just going back to the data about masks and the question that had come up earlier. Someone had asked about CO2, oxygen, whether air could move through. So to put things in perspective, an oxygen molecule is about 0.29 nanograms. A carbon dioxide molecule is about 0.33 nanograms. A COVID virus is between 20 and 500, sorry, not nanograms, nanometers. A COVID virus is between 20 to 500 nanometers. So it's about 1,000 times larger. Which raises the question, how is it that people can tell you that that air cannot go through a mask, but that air is 1,000 times smaller, and yet tell you that the mask cannot protect you from a virus that is 1,000 times larger? So basically, people keep on saying that the mask doesn't work against a virus, which is 1,000 times larger than an oxygen molecule, but somehow it prevents oxygen from going through, but doesn't prevent the virus from going through it. I mean, it's like you can't eat your cake and have it. You either have to accept the fact that the mask can stop the virus, in which case it does, and if you're trying to say, well, it's stopping the virus and it's stopping the oxygen, even though your argument would still not be right, you may actually be slightly more logical. But to assume that something, a virus that is 1,000 times larger can get to a mask, and an oxygen molecule that's 1,000 times smaller can get to a mask or CO2 molecule, it's really just bad logic. I mean, in fact, there's just no logic. As far as a child who's immunocompromised wearing a mask, while other people are not wearing a mask, the risk of transmission of the virus to that child is still 30%. If both parties were wearing a mask and they were staying at least 6 feet apart, the risk is virtually 0%. If they were not staying far apart and both parties were wearing a mask and the other party actually had the virus, the risk would be less than 5%. So masking does make a huge difference, and when only the immunocompromised child is wearing a mask, the risk of transmission is still about 30%. So it is still significant in the grand scheme of things. Finally, on the issue of the CDC, I don't really know whether I can actually tell you that that their data makes sense or that their messaging makes sense. But I will tell you their messaging doesn't make much sense. COVID-19 is not just a medical issue, it's also a public health issue. And it is an issue where the solution lies in herd immunity, mass vaccination, or methods that allow us to prevent the spread of this infection. So when the CDC comes out, knowing the country we live in, and says, well, people who are wearing masks don't need to wear their masks indoors as well as outdoors, there may actually be science behind it, even though technically speaking, you're 19 times as likely to get the virus if you are indoors as compared to outdoors, and less than 10% of the viral spread from COVID is assumed to have even happened in the outdoor setting. So there was complete logic behind saying outdoors, and maybe even some with indoors. But then you have to go to the public health perspective. What do you do in a country where we're not allowed to ask people if they're vaccinated or not? What do you do in a country where even at this point in time, 60% of the eligible adults in the state of Florida, for example, are not fully vaccinated? And forget about the kids and everyone else. We're just talking about adults. And this is something that is common across the country. So then it raises a question. When the CDC comes out and says people who are vaccinated don't need to wear a mask indoors and outdoors, yet leave us with no mechanism for verifying who's vaccinated or not, how is that good science, and how is that good policy, and how is that good sense? Because invariably what you're doing now is, I mean, you're asking us to operate on an honor system, which clearly does not work at this time regarding this pandemic. So yes, I personally feel like the CDC at several times, either through messaging or modeled messaging, has failed us and has created this situation where people are despair. There are lots of people who have children who are immunocompromised, at risk, or maybe not even just at risk, but they don't want their kids to get COVID. And their major frustration now is they don't know what to do with themselves. They're vaccinated. Do they wear a mask when they go out? Do they not need to wear a mask when they go out? Well, in truth, the vaccination will protect you almost 97% of the time based on the Israeli data. And in children, the vaccination will protect you 100% if you can be vaccinated. But then if you've got a child who's 12 or below, or your kid who hasn't been vaccinated yet, or you have someone who can't be vaccinated, right now, what we've done is we've basically thrown them to the wind and said, you know what, God bless you, take care of yourself. We, the CDC, and everyone else, we're laying off. We're no longer going to be responsible for protecting those who cannot protect themselves. We're just going to have people go out there and claim they've got it, and give you no mechanism of knowing whether people were actually vaccinated or not. So the CDC has let people down, and they have to do a good job of trying to get people to understand what they're doing and understand their messaging when they're dealing with a public health emergency. This is not how you do it.
Thank you, Dr. Ajay. Dr. Castrodano.
Yes, thank you very much. I have, Dr. Musinski.
We have
Add
a
something
response from
No, I
Dr.
just wanted
Musinski.
to add to her CDC question.
Go ahead. Dr.
If I may.
Musinski, you're recognized.
Thank you. The CDC has been a trustworthy organization for a long time, and as Dr. Pino pointed out, they were the model agency for epidemiologic and population health in the world. In fact, nearly every country that has a organization like it has patterned themselves after it and named themselves Centers for Disease Control of whatever, China, France, you name it. And so they were a highly trusted organization because they totally looked at the data scientifically and made recommendations according to what the current available data was, even though they might stretch it a bit in order to fit what would happen in society. The other problem is they are always a very conservative organization, meaning conservative, what I mean is conservative in their recommendations for prevention of disease. They went for the most safe recommendation possible, which might not be the most feasible recommendation possible, as we've seen. Now they've been accused of flip-flopping, and unfortunately what happened to the CDC in the last couple of years, they became controlled by political influences that never happened in their history before. So many of their recommendations that they wanted to make weren't made, and they were modified, even at the highest levels of government. That has recently changed, but it's going to take a long time to reverse that. So it's no wonder people are confused as they can possibly be by what they're saying. And it's a little bit disheveled right now in their leadership there, and it's only now starting to reverse. Now, you asked about other resources that you can compare to what the CDC says, and amazingly, there are independent resources out there that are highly respected and very academically fit and scientific, and they really mirror closely what the CDC is saying. I would refer people to the Johns Hopkins COVID project website, and for children, I'd refer people especially to a project called Policy Lab, which is part of the Children's Hospital of Philadelphia research group, and it's one of the premier in the country. And read what they say about the topics we're talking about, because they're pretty much what the CDC says. It's very close. I hope that helps.
Yes,
Thank you, Dr. Musinski. Back to you.
Yes. Okay, so this, I know Dr. Pino has to leave soon, I believe, so I have a question for him, if he's still on the line. But since we are not able to ask people about their vaccination status, or we could, but they don't have to tell us, is the Department of Health able to drill down to the zip code level and ages for those who are vaccinated as a way to monitor the percent of our students who are vaccinated, and then share that with with OCPS?
Dr. Pino, are you still with us? Dr. Pino? think we may have lost Dr. Pino. No, I don't think he's on the line. So,
Okay.
Dr. Jenkins, if you could follow up with that question, that would be helpful information.
Yes, that
Next.
way we can monitor
Yeah.
going forward. Thank you. That's it for now.
All right, thank you. Let's go to Member Byrd.
Thank you. I just want to know if the Medical Advisory Committee could comment on the risk of, or what we've seen with spread from children to children as we look at the masks with the elementary kids not being vaccinated. What kind of risk are we looking at, or have we seen with spread between children to children?
Thank you, Member Byrd.
I'll
Dr.
let Dr.
Kadia?
Kadia go ahead and answer
Dr.
that question
Kadia?
first.
You're recognized.
So there are multiple places you can look for information. It's difficult to ascertain. One good place to look is all these reports coming out about schools. A lot of them, especially with mask wearing and mitigation processes in place, found very limited to no school transmission. However, it was in the homes. Some of the children who were positive at home or at the schools were transmitting it to family members. And then a lot of it was associated with sports, which is what we saw here, right? The competitive sports, any indoor sports, being close together, family gatherings. So children can transmit it. They're less likely to transmit than adults. We know that. We think that. But again, in the majority of schools, when you compare schools, it's hard to see it because schools had different mitigation processes. And even then, I know they weren't always followed. I hear about, schools here where teachers take off their mask and the kids are allowed to. I drill my kids and I know that they never take their mask off, and I hope. Well, they tell me outside by themselves in the corner is the only time they're allowed to do it, not anywhere near anyone. So I know it depends on the school and how well they are implementing that and controlling it, but it's going to be difficult for you to get a good clear-cut answer. But definitely I think those are the studies that we need to look at, and I think that's what the CDC is compiling right now, and so is the American Academy of Pediatrics, in order to come out with these results. And that's why the camp guidance, for instance, I believe they're using what information is available right now. We are talking about flip-flopping. We all did. I was infection prevention, Dr. Sue in his hospital, right? Dr. Musinski. At the beginning of the pandemic, we were changing recommendations almost on a daily basis because of new data that was coming out. We want to do what's best for everybody based on the information that we have. And so right now, the new guidance for summer camps say, if everyone is vaccinated at your camp, great, no masks. However, if you have children, highly unlikely, since to be fully vaccinated for those under 16, you need 2 doses, and it's 2 weeks after the second dose. Very small amount of kids will be there right now, maybe the ones that were in the trials. And so that's why they still say when there are people that are unvaccinated, you should still continue use the mitigation efforts, hand washing, and wearing masks. I don't know if anyone else.
Thank you, Dr. Kadia. Dr. Musinski.
Yeah, I can just briefly add to that. There is some data where daycares were studied, for example, but those are really young children under 2 in general, and they have a really low risk of transmitting virus. And then the younger kids in kindergarten through maybe about grade 4 or 5 are also have a low chance of transmitting amongst each other in school. But we quit getting data on this because everybody put masks mandates in schools. So guess what happened? There was almost no transmission. So we knew that there would be if we didn't have masks, and now we're at the point where we're doing so well, people saying, see, you didn't need those masks because nothing happened in the schools. And the point is, nothing happened in the schools because we had the masks. That's the truth to the matter. The other thing too is it is hypothesized, and there is some studies to show this pretty well, that children have a lower amount of virus in their respiratory secretions than adults do. And it's thought to be the result that they don't have as many of these receptors where the virus attaches to infect you. So the titer or the amount of virus in their noses is less. So just because of that, even though a little baby sneezes in your face and has COVID, he or she's not sneezing as much virus as, let's say, Dr. Shu would be if he sneezed in my face. So he would sneeze a lot more virus if he wasn't wearing a mask. So I hope that helps.
Member Byrd?
Yes, that is very helpful. Thank you. And then the last thing I just wanted to ask about, because I'm still, as Member Castro-Ditto said, getting emails about this, and I realize it is not necessarily directly related to the masks, but I figure since you're here, I'm going to ask. The vaccines, I'm still getting some emails talking about, are not happy that we're promoting getting vaccinated, because there's a lot of people, not a lot, but there's some people that feel that, you know, it's very experimental, and when they look on the vaccine reaction website, there's all kinds of negative reactions happening. So I was just wondering if you guys could briefly speak on that.
All right, Dr. Shu? Help me
Sure,
out here. Who's going to speak to that?
Yeah, I mean, I recognize, first of all, I do want to acknowledge that getting a vaccine is an intensely personal decision. We don't take lightly of that fact that, you know, this is a situation that is just unprecedented, and everyone has to make that choice, and we acknowledge that. And we want people to feel comfortable with the decision as opposed to forcing something on them. Now, that being said, and we've heard this time and time again, there is plenty of evidence out there suggesting that this vaccine is safe. You know, if there are any concerns with the vaccines, there are mechanisms to identify that, no matter how small, and we've seen that with the J&J. Mm-hmm. They're looking into heart inflammation with the mRNA vaccines. The public health, we have our credibility at stake. Both the organizations, the pharmaceutical companies, we want to be as transparent as possible. So, so all those factors are being played in. And so, of course, when we talk about the benefits of it, it's not just, of course, your own personal protection, but it's protection of other people during a pandemic. This is unprecedented. We've given 150 million doses in the United States. To give this many doses and to see its safety profile being validated is just incredible. So we do want to continue to encourage, present the data, let them know how effective it is as well, much more effective than flu vaccine. So, it is. I mean, we don't want to be trampling on, we don't want to be, there's a fine line between breathing down someone's neck and yet saying this is what we need to do as a society for your own sake as well as others. And that's what we are trying to achieve that balance doing.
Member Byrd. I'm sorry, Dr. Musinski.
Yeah, to answer your question, people are going on websites looking at all these adverse reactions that are occurring. I think you're referring to the VAERS website, Vaccine Adverse Event Reporting System, mm-hmm. Abbreviated VAERS. It's a reporting system mandated by law, actually, for all vaccines, and you have to report any event that occurred within a certain period after the vaccine was given, any adverse event. And that adverse event may or may not be related to the vaccine. In other words, deaths are reported after the vaccine frequently. And so when you look at it, the person died in an automobile accident when it was finally investigated, or the person died of cancer unrelated to the vaccine, and things like that, and they were expected to die. Or there are other adverse events, like Dr. Shu just mentioned, the possibility of inflammation of the heart from the mRNA vaccines. But the problem is you have to be able to compare it, investigate each case reported carefully to make sure it really is, because cases are reported not just by doctors and hospitals, they're reported by anybody, and without any background or anything. And so you have to go in there and actually investigate each case one by one to figure out if there's an association. The problem is inflammation of the heart occurs at a rate all the time in people. unrelated to any vaccines. And you just happen to give them a vaccine, and then they get the heart inflammation afterwards. The question is this a related event? And most of the time, these are post hoc propter hoc fallacies, meaning this because of this. In other words, I got the vaccine and it rained today, so therefore the vaccine caused a rain. You know, so you got to be careful you don't make that kind of an logic error when you're looking at adverse events. And so that's why Dr. Hsu said, you know, they're chasing reports on 150 million potential vaccines being already given, and none of them have panned out so far, except for possible exception of the Johnson & Johnson vaccine with blood clots in certain individuals who are at risk for them. So it's incredibly safe. It's safer than any vaccine I know of. The data, I mean, it's amazing how safe it really is. I was shocked by how safe this vaccine was. I figured there'd be some reactions that would be incompatible with giving it to certain groups. Didn't happen. I'm shocked by its efficacy. Who would ever think we would have a vaccine 95% effective? I mean, there aren't too many like that. The measles vaccine is, but not many more. The smallpox vaccine is, a polio vaccine is, and that's about it. Those are the only ones. And so the SARS-CoV-2 vaccine has joined that important group of really high effectiveness. So don't be scared by individual reports. Be worried when the FDA comes out and says, we're putting a hold on Johnson & Johnson because of this. And they didn't jump the gun, I don't think. Some people have accused them of that. I don't think they had any choice. They stopped it, they investigated it, and they decided, okay, we can control for this. It's not going to be a problem if we do certain things, and they released it again. And then left it up to you whether you want it or one of the others. So this is really important to understand that the FDA is not trying to pull the wool over your eyes and force something on you. The FDA is trying to protect you and save you, and soon these mRNA vaccines are going to get full approval from the FDA, not just the emergency approval. That is coming soon, because with all these doses, they will qualify for it.
Dr. Kadia? Okay, Dr. Kadia, and then I'll go to Dr. Ajay. Dr. Kadia?
I wanted to add on to that. Yes, because it's important. We are hearing all of these things, right? Most recently, what we were hearing in the hospital was about the myocarditis, the inflammation in the heart. Obviously, we want to make sure that we follow all of the reports, and that's what the government is doing. On May 27th, so just last week, in one of the good journals for cardiology, they looked at just about 1,600 U.S. competitive athletes who had COVID-19, and they did MRI, so imaging of the heart, and 37 of them, so 2.3%, had clinical or subclinical myocarditis. Only 5 would have been detected with clinical symptoms only. So again, I think it's important for us to hear that, but then also hear that actual disease from COVID actually might have even more cardiac problems that we know than the vaccine. So again, just getting all this story, I think, is important.
Dr. Ajay?
Okay, great. Actually, Dr. Kadir actually just went into what I was going to say, which is awesome. And that's the fact that
Dr. Ajay, we're having a hard time understanding you, sir. It's very muffled.
Can you hear me now?
That's much better. And there's also a
about now?
crackling sound. I don't know what that crackling sound was, but I don't hear it right now. That sounds so much better. Thank you, sir.
Okay, good. Great. So what I was saying is, Dr. Kadir actually started up in what I was actually going to say, which is the fact that I don't want people to assume that these vaccines do not have side effects. They do. And I think it's important that we let people know, yes, you can have side effects from these vaccines. So if that helps them to give them some believe or trust us a bit more, since we're not saying it can't have side effects, I think that's good to know. But what I also tell my patients in general is that whatever a virus can give you, there's a possibility that whatever vaccine we come up with to prevent you from getting that virus, there is going to be a supremely smaller amount of people It could be 1 in 10,000, 1 in 100,000, 1 in a million people who are going to get some of the effects that you typically might see from the vaccine. And that is going to be true. But what also is necessarily going to be true is that the intensity of whatever you're going to get is going to be much less. So yes, people get fevers when they get COVID-19, and some people get fevers when they get the vaccine. The difference is normally within 24 hours, it's over. And obviously, when the vaccination, you cannot infect someone else. It's also true, even when they talk about the Johnson & Johnson and clotting, the fact of the matter is several individuals who got COVID-19 infection clotted had clotting during their actual infections. It's one of the reasons why ventilation was so difficult and why we lost a lot of people early on. It's one of the reasons why we were giving heparin to people in the ICU early on with COVID-19 when we initially started, because we didn't know, because we were seeing all these clotting events happen. We were seeing younger individuals who were having strokes. And the reported episodes of myocarditis were actually occurring even with COVID. So the fact that when you vaccinate millions of people, that you will see some of what you saw during the actual disease or the disease show up in vaccination is not actually surprising. It's actually part of what always happens. What you always look at is what are the real true numbers and what was the impact, the clinical impact, as compared to what was happening with the rare or the live virus, the live viral infection itself. And so I would say to people, yes, there might be side effects, and you're probably going to see every side effect that has been listed for the actual virus as being possibly present with a vaccine. However, likelihood is there's going to be so much fewer, and the severity is going to be so much less. And even when people talk about the mRNA vaccines and they worry so much about is it going to alter DNA, I think it's important for people to understand that the mRNA does not actually make it into the nucleus. It does not alter your DNA. And as your body produces its own antibody, part of what it does is it destroys the mRNA, which was actually put in the first case to actually provide you with the instruction on how to create the antibody. So, yes, there are going to be side effects, but it's nothing compared to the actual disease. And in the grand scheme, it is a good thing to go ahead and get this vaccine.
Thank you, Dr. Ajay. Member Byrd. Okay. Member Gallo.
Thank you. Thank you, Madam Chair. So I have a series of questions, if I may. I do want to go back because we mentioned daycares, and that in daycares there was low transmissions. Daycares were one of the very few places that actually stayed in business, not all of them, but some of them during the whole COVID period. And a lot of those daycares, they didn't wear masks up to the age of 4. So did we see a lot of outbreak in those daycares? Were we seeing it during when COVID was at its height, even with students that didn't have masks on?
Dr.
I
Musinski?
think the answer here, we're talking amongst ourselves, who knows the answer. It's a good question, really good question. It's been said that there's less transmission within a daycare setting than within a school than within homes. Homes, the risk is much higher. So if the child did get COVID at home, they're much less likely to give it to their classmate than they are to their grandmother or unvaccinated grandmother, unvaccinated parents. Where it definitely has been shown to happen. That'll happen. Kids give crud to the parents all the time, right? When they come home with colds and everything, everybody's used to that who's a parent with kids in school. The other answer is what Dr. Kadia just told me, which I don't know if you heard her, was that there was a paucity of testing available or even occurring in the time of the pandemic when you could measure such an effect. So there weren't, unless there was a specific study actually done purposely in the daycare, we weren't getting that data. And we were just waiting for someone in the daycare to get sick with the disease before we can actually test them and confirm that they had it. So you might also know that the asymptomatic infection rate in children that young is very high, meaning they get infected but they have no symptoms, but they're still contagious. Much less so than kid with symptoms, but they're still contagious. So The vast majority of cases were asymptomatic, never measured. The few that were looked really low in numbers, so they made the conclusion, I guess not much COVID occurs in daycare. And I think the answer remains still to be totally defined. But now that the pandemic has dropped to such low levels, the risk of introducing, if a lot of parents are vaccinated and all the staff at the daycare are vaccinated, the risk of introducing COVID into that daycare is even lower than it was when things were low to begin with. So daycare may be, best word I can give you, may be safer than a regular school.
So, with the
Member
limited
Downs?
information that I guess we have on daycares, we're looking at 4-year-olds versus 5-year-olds versus 6-year-olds. What would change? Like, what would be the difference between a 4-year-old? Like, what changes in an elementary school? What would exist in elementary school that would cause more of a transmission that wouldn't exist in a daycare when we know those daycare students didn't wear masks? What is the different denominator? What's different within our schools that would make us believe, or research would show us, that there would be a higher transmission rate amongst those children than in daycares, when we truly didn't see it in daycares when those children weren't masked?
This would just be hypothetical stuff.
Can I speak? Can I speak to this?
Yeah, go ahead.
Dr. Ajay, you're recognized.
Great.
Yes. So, a couple of things. From a physical, if we look at it and just break it down in a couple of different ways, a child in elementary school as compared to a child in daycare is a much bigger person, much more mobile, so they have more environment that they cover in general. They have bigger lungs. They're capable of harboring more virus, and they're capable of coughing over longer distances as compared to someone who's in daycare, who is in a more limited space, probably in just one room with a few kids, as against a child who is able to maneuver and move around and huddle with more kids, touch more things, hold on to more things and stuff. So just in terms of the environment, a daycare individual, a child, and an older child have vastly different ranges. The other thing is, even if you think about it just in terms of their height, a daycare child who is probably in a crib, maybe just about a foot and a half to 2 feet tall, just toddling around, even when they cough, and if you just look at the deposition patterns of that cough, they're already close to the ground, everything's going down quicker. So your need for social distancing and the amount of space between them might actually be less, because they don't push as far and they're much smaller, so there's more deposition in a small area around them. As that child gets taller, bigger, your cone of deposition becomes wider. And also, because they've got a stronger cough, the reach of that cough also becomes further. And because they're also capable of harboring more virus, the viral load that they carry is also higher. So there is a real significant difference between a daycare child as compared to an elementary child. But it's also similar to how I would tell you that there's a significant difference between an elementary child and probably a middle or high school child for those same anatomic and physiologic reasons that I just described. So a daycare child and an elementary child are not the same at all when you're looking at them just in terms of physiology, movement, and spread in general.
Member Gallo.
Thank you.
Thank you, Dr. Ajay.
Thank you.
Dr. Musinski?
Real quick, to add to what Dr. Jai said, little kids are much less likely, kids under the age of 2 are much less likely to spread whatever virus infection they have by aerosol, which are these fine particles that travel around the room and last in the room for a long time, up to hours. Whereas older kids, by that coughing mechanism he just talked about, are more likely to create aerosols. And we now know, it was denied for a long time by the WHO and World Health Organization as well as the CDC, that aerosols weren't important. And at first I kind of felt that way, then I started seeing the data that aerosols are really important. And thank goodness Superintendent Jenkins, the Orange County Public Schools adopted improving the ventilation in schools, which really made an incredible big difference. And that study that Dr. Kadia mentioned in Georgia also credited improved ventilation with HEPA filters and UV lights and things really made a big difference in that scenario. Most daycares don't invest in 12 air exchanges an hour, ventilation, and big-time HEPA filters. Most of them don't in situations. So, but they don't need to probably because there's no aerosols there. Yeah, but in bigger kids, aerosols are everywhere. And boy, Dr. Ajay is right. Anybody over the age of 11 transmits the virus as efficiently as I would as an adult. So that's the other thing you had to keep in mind. So I'm glad we have vaccine now down to 12. Hopefully those kids will get vaccinated.
Member Geller.
So, and then I too, as my fellow board members, have been receiving tons of emails with questions from parents because there is a lot of different research that's out there. There's just a lot of misinformation and a lot of information out there that's flowing. So most of the arguments that have been made to me on why masks should be optional in our schools is that there's a low risk of serious illness for children under the age of like 11, and that masks worn by children aren't as effective as masks worn by adults. Like, I don't know if research shows they're messing with it. It's not tight fitting. It's not appropriate. So therefore, it's not really controlling it. But that the effectiveness of the mask is just not as effective for children. And the other argument that I've heard is that children, which I think we've discussed here and have determined that children have a very low risk of infections, and they really aren't the driver of these viruses. So why are we masking our children when there's low risk of transmission? Masks aren't effective. And if they do get the COVID, it's not a serious disease, and they, for the most part, do not end up in the hospital.
Anybody want to take that, Dr.
I mean, we can all answer.
Yeah.
Well, let's not all. Well,
So yeah, I'll just go ahead and get that started. Children do get infected. You know, to say that they don't get infected is not true. They do get infected. Yes, it is true that they are not at risk of as serious illness as adults would be. You know, and however, there are significant complications that can occur, even though they may not occur as frequently. And again, probably the most important thing is that they can still drive transmission, not just within the schools, but to their homes, to their families. You know, again, as the number of vaccinated people increase, that should go down. But we're still in a pandemic, and everyone wants to get back to normal. We understand that, but that means that every segment of the population also needs to be able to do their part to reduce the risk of transmission to others. So maybe from a clinical standpoint, the risks are lower for significant infections, but the public health aspects are still very important. And by not wearing masks or not getting vaccinated, if you have the opportunity, you are basically delaying the progression to get back to normal. And so that would be my response. I'm sure there are other responses from other colleagues.
Okay. I thought that was pretty good, though.
Yeah, but you
Dr. Musinski.
you heard from us before that there's definite evidence that children bring home COVID to their families and have infected their grandparents, who might be elderly people who were living at home, and with tragic consequences in the height of the pandemic. Yes, their rate of disease was lower. They are now the segment of the population that is the unprotected segment, and the chance of getting infected is increasing. You heard that nearly 1 in 10 children get hospitalized when they get it. That's hardly benign. And about somewhere in a range of 1 in 10 of those end up in intensive care, which isn't benign. So the question you want to ask is, we know masks are effective, and even if the kid's ripping it off now and then, but getting it back on, you know, and then readjusting it and playing around with it all day long, eventually, hopefully the child learns that this is part of the social way things are during COVID time. And to say then, let's just get rid of all of them, I would ask how many hospitalizations of a child is okay to stop mitigation? How many kids allowed to be in the intensive care unit is acceptable to you? How many children with multi-inflammatory syndrome of childhood, which is an event that occurs post-COVID about anywhere from a number of weeks to a month later or so, where the child has a disease very similar to what's called Kawasaki syndrome, but it's not the same, where it's a devastating infection that can injure their heart for life, their lungs for life. And we don't know if children become long haulers or not. And it appears that more evidence is showing that they are, that they have symptoms that persist beyond their infection. So I would just ask you, what is the limit of the number of all these bad things that are occurring in children, thousands of them now with the multi-inflammatory syndrome and ICU stays that are very long and very tragic? How many of those are okay? Well, let's rip off the masks and find out if it goes up. You know, and that is where we're at right now, I think. And I, as a pediatrician, I'm sure Dr. Kadia would agree, and Dr. Nielsen also on the line, and Dr. Schwartz, we're all pediatric people. We would agree that there's no child number that's acceptable, and our goal is to make it as low as humanly possible. So that's why a lot of times our recommendations seem stringent, but that's the rationale behind them. As a pediatrician sworn to the care of children.
Thank you. Dr. Kadia?
I will just echo everything that has been said. Studies that show that they don't work, haven't seen those studies. I have a handful of them here showing that they do work. Again, also along other things that we've been doing. So masks just by themselves, you know, we'll see. But like Dr. Musinski was saying, one death to COVID in a child is one too many. How many things are we doing to prevent deaths? OCPS recently started screening high school athletes with EKGs. One death is too many, right? We have lost children. I have had kids this last weekend that have been in intensive care unit in relationship to COVID. It's wonderful how different it is this year from last year. Last year, it was extremely difficult for me to get any testing done in a child right now. Now I have some improved means. It still takes me a little bit of time. We do know what to do. We're more comfortable. We have success. We've seen success in our hospital, but we don't know what the long-term effects are for these kids that have had any of these acute COVID illnesses, MIS-C. They are real. We are seeing them from a vaccine preventable disease. If there was no vaccine in the horizon, then maybe we would be having a different talk. But how can we not prevent childhood illness and deaths when the vaccine is right there? I have seen a 2-year-old infect a fully vaccinated adult. It can happen. It's rare. Adult was fine. But what if that was an immunocompromised host? What if that was somebody who had high risk and ended up dying or ended up extremely sick? Again, it's in the horizon. These vaccines are coming soon. From what we're hearing, 5 to 11, early fall, 2 to 5, late fall, early winter. It's only a few more months to prevent comorbidities and mortality. That's.
Thank you, Dr. Kadia. Dr. Ajay. Dr. Ajay, are you on the line?
What
Thank
I was
you, sir.
actually going. Can you hear me now?
Yes, sir, we can.
Can you hear me?
Yes.
Okay, good. What I was actually going to say, in addition to what Dr. Kadia and Dr. Musinski have said, is when you think about this virus, we have to remember it's not just a personal thing, but it's also a public health issue. This is a virus that is capable of mutating. And the longer the virus stays around with us, the more likely it is that this virus mutates. And it doesn't matter whether you're a little child or whether you're a grown-up, the mutation process can start in any one of us. right now we have vaccines that are pretty effective against what we have, but we know this virus continues to mutate. The sooner, as a community, that we get to a point where we have eradicated or got this virus down to such low numbers that it is no longer spreading among us, the better the likelihood that we will quell this thing before it potentially mutates into something that may render everything that we've done so far useless, in which case we're back to square one, or it may actually just make the virus entirely, it may actually make the virus to have no potency, in which case we would be lucky. But the fact of the matter is, although we're looking at children and saying, well, they're not severely impacted or they're not big spreaders, they are still capable, because they're part of that pool in which that virus continues to make its changes and its mutations, that as part of society, if we don't stop it with them and not just with the adults, we could potentially end up back where we started, and it may even mutate to a point where it becomes incredibly dangerous in children. So we don't want to wait for that to happen.
Thank you, Dr. Joy. Dr. Nielsen.
I completely agree with the three fabulous physicians who just spoke in front of me. I just kind of want to implore you guys to remember, it is hard to be a leader. It is hard to have to make decisions that are so wide and so broad. But I think you do have to look at what Dr. Ajay was just saying. We know that these mutants, these variants are developing quickly. And like Dr. Musinski had said earlier, we know this is the group that's starting to have it more. I just came back to this conference because I saw a 6-year-old who has it, and he's on his way elsewhere to be treated further. So we do need to be cognizant and aware that it's summer, kids are out of school right this second, and it's still prevalent. And until they can be vaccinated, I feel very strongly that that age group, we have a civic and medical and moral duty to protect them by saying, let's keep a mask on these kiddos until they and their families have the opportunity to be vaccinated. That's all.
Member Gallo.
So thank you, and thank you for that. I really appreciate all the responses, because there is a lot of misinformation, confusion, and as school board members, we're the ones answering emails and trying to explain the research that they're throwing out at us. Another research that, a piece of research that was given to me, it came from Dr. Peter McCullough, he's the vice chair of medicine at Baylor University, and I guess he's spoken at length to the U.S. Senate, and he's also spoke to the Texas Senate. He's from Texas, obviously Baylor. And he's making the argument that the reason that we're having so many cases and we're seeing so many deaths, especially amongst our youth and adults, is because of the standard of care, that we focus too much on getting the vaccine, getting that push forward versus the treatment. And when we did look at treatments, we only really looked at 1 or 2 drugs in isolation and not together, where when you look at AIDS or you look at other diseases, there's usually a cocktail of drugs that we use to treat it, to manage the symptoms. And his argument is that there's no standard of care, and we're not teaching doctors how to treat COVID, because if we would focus more on the treatment, we'd have less hospitalizations, less deaths amongst students and adults, and that was a really issue. And he's written some papers, and they've been peer reviewed. And he's saying that there should have been a panel of doctors, not just one doctor. It shouldn't be just, or even the people that were on the panel for the White House, none of them were actually doctors. None of them actually treated COVID. So my question is, because I know we do have doctors on this panel that have treated COVID. We have pediatric doctors that have treated COVID. Is there a standard of care? Are there treatments available? Do those treatments help our students? And will those treatments keep them out of the hospital currently?
Doctor?
Member Gallo, thank you. Hard to know exactly where to start. I mean, preventing a disease is so much more effective, more cost effective. It's just better than having the disease, right? I mean, I think to that effect, I think all of us would somewhat disagree with the assessment that treating is more important than prevention. Prevention is still the key to this. Now, that being said, treatments are important, and the standards of care have evolved over time. It takes doctors many years sometimes to adopt standard practice of cares with evidence-based medicine, given the system. And yet we have been able, in this short time, to somehow get some standards out there. The NIH is the reliable source that many of us look at as far as looking at the trials that have been doing. We know steroids work. We do know that, remdesivir makes a difference. They are looking at monoclonal antibodies for early infections, has recently expanded to more individuals as well. So there are standards out there. Viruses are notoriously difficult to treat, much more difficult than many bacterial infections. So, we have come a long ways. And yes, could we improve the standards of care in organizations? Yes, I'm sure we can. But overall, the focus really should, while we continue to focus on standards of care for treatment, we still need to focus on prevention, and that's what the vaccines are for.
Could I add a little something there? I do think, obviously, based on the questions you all are receiving, and we've received a lot of those as well, misinformation is one of the biggest things we need to combat. I think one tool that has been so fantastic through this whole year, is this on? I'm sorry, are the community updates that you have, several of you have put out, Dr. Jenkins for sure. And I think it's very progressive that OCPS is doing the vaccine clinics where they're going to the schools and encouraging, because it's hard to reach that age group, particularly in the summer. So I do hope that educational tool and those will still be offered, because really, it's a great way to combat misinformation and provide a solution by making those available.
Okay, Dr. Ajay, let's go to Dr. Ajay. Then Dr. Kadia, then Dr. Musinski.
Yeah, personally, okay. Can you hear me?
Yes, sir, we can hear you.
Okay, great. Just as Dr. Xu said, I think it's horrifying that anyone assumes it makes more sense to wait to spend more time and effort on treating people who get sick rather than preventing people from getting sick. It's part of the problem with how we got here in the first case. In general, the United States, I think, as compared to a lot of third world countries, doesn't do as well with preventive medicine because it has all of this excellent technology and it assumes it can treat everything in hospitals. The problem is what happens when you get something you've never treated before. Suddenly, if you don't know how to prevent illness and all you know to do is treat, now you're in a bind because you don't know how to treat illness. In the case of COVID, we're talking about a disease that's only about a year old. In that year, we've learned so much. Whatever treatments anybody used back in January or February of 2020 is probably not the treatments that they're using today. And quite frankly, it's very likely that given the advances in technology that we have, the treatments that will end up being used towards the end of 2021 and probably in 2022 will probably change again and be more varied because we keep on developing, which is the right way to do it. However, the reality of COVID is your number one goal is to prevent people from getting it. Nothing, plain and simple. People think about COVID, but you don't think about the implications of a disease that can go into your body, can clog up the blood vessels in your kidneys, can clog up the blood vessels in your lungs, can affect your sense of smell, which means it affects your olfactory nerve, which goes all the way to your brain, can cause clots to develop in blood vessels that go to your brain. Has anyone ever considered what the long-term implication of getting COVID might actually be to us? What's going to happen to our kidney function long-term? I have young individuals that I take care of, 16, 17-year-old athletes who had COVID, and 4 or 5 months post-COVID, their lungs are still shot. Their stamina is poor, and even when their lung functions return to normal, their stamina is still poor. So the question is, has there been impact on them from a cardiovascular perspective? This is not the disease that you feel proud because you were able to treat it. The only time you should feel pride is when you're able to prevent it, not when you're able to treat it. Yes, you want to treat it if it happens, but your primary goal is to actually stop people from having this. So any school of thought that suggests that The problem is the fact that we focused on preventing it rather than focused on treating it. Wow. But I think it's probably just best to leave it at that. But the truth is, it makes more sense to prevent this virus from happening than waiting to treat it. You don't want to do that. Imagine telling people that had measles or people who had epizootitis in the past that it was okay to have your kid intubated if you had epizootitis, or if you had measles, it was okay to go blind, simply because we could have spent more time figuring out how to treat measles instead of preventing it. Or telling people with polio it was okay for your kids to go lame, but that we should have focused more on trying to treat polio rather than prevent people from getting it. I mean, there's no logic to some of these things, but there are a lot of people who consider themselves experts, and there are people out there who, quite frankly, they are qualified physicians and qualified scientists. But it doesn't mean that we're all going to see things the same way. And the question is, who's really looking at this from a human perspective and who's being political about this? But neither here nor there. I just say the better approach is prevent rather than focus on treat. And if we had the treatments we had today, 12 months ago, a lot of those people probably wouldn't have died. But that's why we prevent disease, so that it gives us more time to help save more people rather than see more people die.
Dr. Jenkins, you had your hand up. That we have another member of MAC on the call? Okay. All right, let me take a roll call here. Just how many MAC members want to respond to this still? I think everybody? Dr. Musinski? Member Gallo, after this round of answers, I'm going to go to the next board member and we'll circle back over.
Okay, perfect.
We've been
Thank
here
you.
for quite a while, and everybody else is lit up. So let's hear from Dr. Nielsen. Dr. Nielsen, you're recognized.
Thank you. As far as standard of care for treating COVID, the problem is that no two kids that walk into a pediatric office necessarily look the same with COVID. So although I would love to be able to say, oh, just take some amoxicillin, you'll be great, that's not the reality of it, because I might have one child who's got horrific dehydration. I might have one kid who has a runny nose. I might have another kid who has a fever of 105 to 107 for 5 nights in a row, bloodshot eyes, bloody red lips, and I'm calling Dr. Kadia to talk. So I think the problem is with kids, and probably with adults, but I don't take care of adults specifically, is that no two cases are the same. So while there's great ideas and great suggestions of how to help them, it truly is symptomatic support. And I think anyone who says, oh, I can go down this protocol of a standard of care for a child with COVID is missing the boat, because it's such a new disease. We don't know. You may have a kid who's got clot issues. It may present as respiratory. We in the practice have a baby who had an ileus and had to have part of her intestines taken out. We have new onset type 1 diabetes as a result of this. So we're having other illnesses in conjunction with COVID. So while I would love for there to be a standard of care, there's just not one. It's a standard of what am I going to do for this kid in front of me? And the best way to not have it is to prevent it. Because once you get it, you don't know where that kid's going to go. They may just lose their taste or smell. I've got one kiddo who got it in July last year, and everything she eats or drinks still tastes like rotten fish. So now we're talking about an eating disorder because she's so scarred from this, she doesn't want to eat rotten fish anymore. So I think, anyone saying that there's a standard of care, there's a standard of how to treat symptoms, but you have to figure out which each kid has. That's all.
All right, thank you. Dr. Musinski.
Yes, Dr. McCullough is an adult physician, takes care of adults, cardiovascular. So he sees a lot of people in ICUs and stuff who got COVID early on in the pandemic. So it's hard to extrapolate what he thinks to children. However, his call for protocols once someone is sick and careful randomized controlled trials, perhaps, of all types of therapies that might not help, are actually prudent recommendations to get more information and more data on how to more effectively treat COVID once it's happened. The problem with that is I think some of his words were taken then to also come to what preventing it, because he did make a comment once on the news media that no one under the age of 50 really needs the vaccine because they're at such low risk, which if I was under 50 and I had 3 stents in my heart and heart failure, I'm not at low risk. So I don't know what he was talking about there as a cardiologist, but he actually made that statement. But nonetheless, what Dr. Shu is getting at, there's 2 ways to approach a disease. There's actually 3, but I won't get to the third one. But there's 2 ways. One is what's called primary prevention, and the next one is called secondary prevention, and the third one is the one he's talking about, treatment when it's too frickin' late, the person has the disease and it's bad, right? Primary prevention is by far and away the most effective way of preventing the disease in the first place. It's cost effective, it saves on morbidity, it saves on mortality, less people die with primary prevention. You could think of other things, primary prevention. What are the 2 major killers ahead of COVID, by the way? COVID's number 3 right now. What's the 2 major killers in the United States? It's cancer and it's cardiovascular disease. Now we could just wait till people get cancer and heart problems and say, okay, we'll treat you now with these wonderful protocols. No, we need protocols for prevention, right? So that's primary prevention. So get people the right diets, eat right, if they have risk factors, follow closely, et cetera, et cetera. So you don't want to wait till the person's in heart failure before you start preventing heart disease. That's secondary stuff. Primary prevention in a vaccine is paramount. I mean, if you vaccinate everybody against measles, you have eliminated the chance that anyone's going to get measles ever. So no one's ever going to die from it again. Why would we wait till someone got measles before we did something? Same thing with polio. I mean, who in the right mind would say, oh, we need a polio treatment protocol, we got to find a drug to treat polio, you know? Well, that's unrealistic when we have a vaccine that totally prevents it. So you got to look more at the logic of it yourself and say, ask yourself, so what do I want as the end result? The end result I want is nobody getting COVID. If I could help it, what's the best way to get there? It's not protocols of treatment. That might save lives once they're sick, but will really get us there, even prevent them from getting to Dr. McCullough's ICU, is to vaccinate everybody. That's the bottom line.
Dr. Kadia, nurse practitioner, do you have anything you want to add that hasn't been said? Go ahead, Dr. Kadia.
I would just add that the amount of collegial support during this pandemic has been outstanding. We have been sharing ideas globally from when this first started. What could be tried? Do this, do that. So now, once you are sick enough and you're in the hospital, we do have a few things that we know work well, things that don't work well. And one other thing I just throw out there is pediatrics is different. Kids aren't just little adults. Trials occur in adults first most of the time. We extrapolate adult data. So a lot of these drugs that may be available for adults right now are not really available for me, just like we're waiting for a vaccine. So it truly is an art to practice medicine, pediatrics. But I do have to say that we have shared data and we are collaborating across to make sure that when someone does get sick, we are doing the best that we can to cure them.
Thank you.
Thank you, Dr. Kadia. Okay, let's hear from Member Cobert, who's been on the line with us. Member Cobert?
Thank you, Chair. Can you hear me well?
Yes, we can hear you well.
Thank you. So I'm listening to and very much appreciating this robust discussion and very much depend on the expertise of our medical professionals. So I'd like to offer, I'm using that lens to go back and look at the policy that has been proposed. And I'd like to offer an amendment or addition should the policy remain in its current form. I realize we'll have 2 more meetings and more discussion on this, but in its current form, knowing that the timeline for the vaccine availability for children under 12, or not knowing that timeline for vaccine availability for children under 12, and knowing that when it is, not 100% of parents will make that choice, nor can it be required or reported. And knowing that this policy allows the superintendent to adjust the rules should circumstances change, I'd like to offer up for consideration this addition to the policy that would read, for individuals who are medically fragile, immune compromised, or unvaccinated, face covering is medically recommended. Staff would be able to wordsmith that. But if it remains in its current form, and not knowing how other board members feel about it in its current form, I offer that amendment as a compromise. Thank you.
Okay. Let's just let that sit out there for a minute and take a couple more questions. I think the only concern I have about that is when we say medically recommended, is exactly who are we referring to in terms of that? So I think we need to think through whether it's how we define medically recommended. I certainly will have people who will have other medical recommendations that they will point to in the amazing wealth of information out there on the internet that would argue that it's medically advised not to wear a mask. We all know that you can find anything you seek on the internet these days. So I want to think about that term, but we'll take some input from board members as we go through. Let's go to Member Castrodeno.
Thank you, Madam Chair. I have, first, I appreciate all of the information you guys are sharing. I feel so much more confident in what I think our policy should be going forward. However, there's some areas that I need a little bit more information. And one is about whether children who have been vaccinated can forego a mask when they're playing outside or at recess. And what is the difference in levels of risk between indoor transmission versus outdoor transmission?
All right. We get one person that wants to answer that. Dr. Shu?
Sure. I mean, if a child is able to get vaccinated, the risk of transmission, getting the disease or passing on to others goes way down. So if your question is after a child has been fully vaccinated, did I misinterpret you?
Before they're vaccinated.
Oh, before they're vaccinated. I mean, so let me just discuss the risk of indoor versus outdoor. The risk of outdoor transmission we have seen are much lower than they are indoors, and it's a basic law of physics where you're dealing with an environment in which there is so much air outside and dilution effect is great. And as a result, the CDC has made it very clear based on the data that risk of transmission outdoors is just much lower, and many activities can occur without having to wear face masks. And not have that risk of transmission. In the indoor setting, there's still a risk because you're dealing with an enclosed airspace, and that's why the importance of distancing, good circulation still remains important. It really depends upon the environment that you're in. And if you're in a smaller room that doesn't have good circulation, the risk of transmission in that setting are much greater. So that's really, that is the reason that the CDC may have, they have a tiered approach to mask wearing indoors versus outdoor. It all has to do with the aerosolization of the virus and the ability for that to dilute with a large airspace in outdoor settings.
That answer your question? Satisfactory?
It doesn't really help me make my decision about that. I understand what you said, but I don't hear any definite way to go. Dr. Musinski, I guess, can follow up too with some more information.
Yeah, well, there is really no doubt, looking at transmission data, that outdoor settings are much safer than indoor. There's no question about it. In fact, there might have been just a little bit of overkill requiring everyone to wear masks in outdoor settings regardless of distancing. When you're outdoors, even the slightest breeze will dissipate the virus and its aerosol to such degree that you're really safe if you're basically almost 3 to 6 feet away from the person. And if you're wearing a mask, then the risk is near zero. There's a slight risk if you're not wearing a mask. A way to visualize it, I know this isn't medical data and things like that is concrete perhaps for you, but the way to visualize it is imagine these respiratory droplets as tiny little bubbles that you're generating just like in a kid's bubble machine when you breathe, right, through the little bubble hole. And these bubbles are going forward. Where they go, a lot of them drop straight down because they're big bubbles and they go down, and other ones kind of float around for a while, and those are the aerosol bubbles. So if I'm indoors, those bubbles will move pretty far and kind of hang around a while, right? If I'm outdoors, they blow all over the place and half of them break and just fall apart. And that's what happens to respiratory droplets outside. So the outside effect is very, very strong. Now, also, there were data to look at equivalencies because people worried that a lot of older school buildings and many school systems would not have the proper air exchanges that would get rid of aerosols, another way the virus might more effectively transmit to other kids. And they didn't have the filtering systems either. So if you couldn't put a filter system in because of cost or some other restrictions due to the way the building is so old, the way it was built, the way you got to safety that they showed was to have what's called an outdoor air equivalent within the room. And that would be accomplished just by really ventilating the daylights out of the room with the windows open. And that's one way to do it. And that was shown to be just as effective as being outside. So when I think the committee last met or recently met, we kind of went along and agreed that recess, you really don't need masks at recess. You just need it when you're close to each other in the school at the time when the rates were much higher than what Dr. Pino told us about today out there. The risks were much greater. And so I think that being outside is the safest place you could be, including restaurants, every place else. But if you're vaccinated, you're likely safe everywhere, provided you're not immune compromised or on medications that make you not respond as well to vaccines, et cetera, et cetera. And it all falls down to protecting the unvaccinated. And we'll get back to that question. We've got these little kids who are unvaccinated, and we're going to put them pack them in the rooms. So their only super spreading event that was documented in great detail that was outdoors was during the height of the pandemic at the ceremony for the new Supreme Court Justice at the White House. That thing was outdoor super spreading event. So those weren't too common. But get everybody together in a big auditorium in Tulsa screaming and yelling, you have a super spreading event there because it's indoors, even though it's a big place. And super spreading event, a church choir practicing in a church, in a small room. Boy, boom, super spreading event. But outdoors, it's very rare to have a super spreading event unless you're really in close proximity with people and you're touching and hugging them and breathing in their faces. Then you got a problem. But now, when you're vaccinated, all that goes out the window. So we pediatricians are hoping and praying that that vaccine gets out there as soon as possible. Because we've seen enough death from other vaccine-preventable diseases in my career. I saw kids dying all the time of meningitis. Now it's bacterial meningitis. Now it's a pretty uncommon event, pretty rare. I don't know the last time I saw Haemophilus meningitis. It's been decades. And I used to see 12 kids a year die from it, you know, just in my one hospital. And now 0. And that's where I want to get with COVID. I don't want any kid to ever be hospitalized ever again due to COVID or get multi-inflammatory systemic disease, which is called MIS-C. I don't want to see that ever again.
Thank
So
you.
I think, but outdoors, to answer your question, I think recess is one of the safer places you could be, even without a mask.
Thank you. I appreciate that. Thanks. That helps.
Okay.
That's all.
Thank you. I don't think we have any MAC members on the phone. I'm showing, but I think we've already handled that. Dr. Jenkins, thank you. Dr. Felder.
There we go. Thank you so much. Again, we have just gotten a wealth of information from my medical advisors and other board members who've also been reading and researching. But I just wanted to say this. I'm still struggling with finding ways to convince people that I know that I'm around on the seriousness of wearing masks, and listening to the pediatricians when you talked about the child, you know, they may get the disease and they may get healed from it, but the residual effects, like you don't know how long it's going to affect lungs or things of that nature. And a child is 5 or 6 or 7 or 3, that's frightening. And it's, you know, I'm a dramatic person, and I know we may not can use these extremes, but I remember when people were really concerned about sickness, they would have these billboards up. I never forget, I was teaching at Dr. Phillips, one of my friends who at the time, Phyllis Robital, she was teaching physiology and anatomy, and she brought over a black lung to my class in a jar. And I was, one of my extracurricular activities at the school was to work with children who had smoking problems. So I used that as an example. And when the children saw the black lung, then they were able to understand. They had a visual, what I'm saying. I say, now you're 12, I mean, you're 15 and 16, but think about when you get my age of 45 at the time of 30, what could happen to your lungs. And so everybody, some of the people are not really seeing the seriousness of wearing the mask, practicing the social distancing, and you know, like we know, people will pull up anything on the internet and think that's factual. But I think this district has gone an extra mile to try to talk and find people who are expert in what they do. And this session today, even though I have been listening to some things, but today, thinking about the residual effects of sickness, and I'm thinking about my own personal experience as a child when I had measles. I had encephalitis, which was complication from the measles. And at the time, it was segregation, and black children had to go to the basement of what you know as Orlando Regional was called Orange Memorial. I had a white pediatrician, and my parents were very concerned about them being able to wait on me right away because some of the nurses said that she's a colored child, she can't go right in. But he stepped in, this white pediatrician stepped in and said, if I don't wait on her right now, she'll die. And I wear glasses as a result of that because encephalitis affected my eyes. My point is the residual effects of disease. And I just, if I could find a way in the time that we have to come back again to discuss this, if I could have something visual to share with members of my constituency and people that I know who still are not convinced that you need to wear masks, that you need to be vaccinated. This discussion, I don't know how many, I've been texting people saying, get on, watch this, we're in a work session, listen to what we're talking about, to let them know. I almost feel like if we had somebody with a billboard on I-4, this is a kid who was diagnosed with COVID. This is 3 years later, 5 years later, this is what's happening to his lungs or whatever. I know that seems drastic, but we're living in drastic times. So I just wanted to say that, and it's a lot I want to say, but I'm going to stop. I just want to thank you for what you have done. I'm so grateful for the energy of this board and our superintendent who wants to dot every I, cross every T before we make any lasting decisions. But this is so very, very serious. And I hopefully during the time before we come back again, I can find some more data that I can share with people that I know who are still not convinced of the seriousness of finding preventive measures to do the best that we can to not only protect children, but to protect the workforce in schools. So thank you so much.
Thank you, Member Felder. You know, I appreciate that concern, and one of the biggest challenges is we don't know what long-term effects there will be to our children. But I think that your point about the unknown, we didn't know when you and I were kids that cigarette smoking, well, maybe we kind of started to know that cigarette smoking could cause cancer. I'm not quite that old. But I think your message is really important. I think it was Dr. Kadia who talked about a child who everything tastes like fish. Wasn't that your example? Dr. Nielsen. So if between now and the time we have a work session, if anybody is able to gather any other information, but in the meantime, I think the fear of the unknown is a reasonable enough reason for people to take this very seriously. Let me go to Member Lopez.
Thank you, Madam Chair. I just have 2 questions, just for clarification, because I know we have a lot of parents listening to us. So my first question is, what is your opinion of making the wearing of face covering optional? That's the first question. And the second question is, what are your recommendations for the students and staff members who needed to use the mask in this type of setting?
Dr. Jenkins. What'd you do?
Got it.
Thank you.
So just for clarity,
Uh-huh.
because I did tell Mac that they would not bring a formal recommendation.
Oh.
So I want to sort of change your question to say opinions or your thoughts about, because the MAC is not bringing a formal recommendation at this point. I didn't want anyone to think I had reneged on my direction. Thank you.
And so what if we do this, because I think you're asking each member, so maybe we could just get a quick answer on your opinion. So we're starting with Dr. Kadia.
My opinion is that until every child who is a school age has the opportunity to be vaccinated, should they choose to or their parent choose to, we should continue masking in order to protect them all.
Dr.
Yeah, I mean, there's a lot of factors to consider. I mean, clearly, if not everyone is masked, it affects other people. If it's optional, there's a chance that those that choose not to wear the mask can affect others. But we also have to look at the community prevalence rates, for example, and see where we're going with that. Because at some point, you know, there is going to be a point when the numbers drop where we would not necessarily need to mask anybody because the prevalence is so low in the community. So we have to just wait for that. So I think my answer is right now, it depends, but the safest route at this point, if I had to make a decision right now, would be that I would prefer mandatory masks in those children that are unable to be vaccinated until we get more data.
Dr. Musinski.
Yes, you ask a really good question. I think the answer is, do you want to be somewhat safe or as safe as you can be? There's no such thing as safe. You're just safer by doing certain things. The safest thing to do with our current knowledge today, in my opinion, would be that anyone who is unvaccinated, whether they be on staff, vendors, or whatever, ought to wear a mask. And seeing that we can't determine who is not vaccinated, it's hard to enforce that. So with we do know that children under 12 are not. So requiring them to wear masks is safer than letting it be optional according to whatever anybody wanted to do about it. That said, I just want to tell you that I'm not a flip-flopper like I've been trolled on the internet for being, because I change my thoughts and recommendations later on, or my opinions later on. I change them because there's new data that refute what we've previously thought. So Dr. Hsu is very cogent in this by saying our rate per 100,000 population may be down under 10 by the middle of the summer, or it might be back up to 120. Those two scenarios are totally different. If it's down under 10, then optional masks is reasonable in a community epidemiologically. But if it's back up over 100, no, it's not reasonable from a safest prevention standpoint. So ask me again in September, my answer might be different than now. And ask me again after the vaccine is getting in the arms of kids between 5 and 12, and I'll have a different answer then. And what I could see, though, on the trajectory is every answer I'm going to give down the line is probably going to get more optimistic and more optimistic, especially if we vaccinate. So I hope that answers your question. I'm reluctant to take the masks off of everyone. The other thing, Dr. Jenkins, I think that there needs to still be a virtual option, of course. I know there is, not that you can offer for kids who are like, if you had a renal transplant child on a rejection preventing medication that harms their immune system, as a parent, would you be safe sending your kid where masks are optional just so they can hang around their buddies? I mean, that is asking for real trouble. That kid is really, and that kid likely will not respond well to the vaccine. We're seeing transplant people not responding to this vaccine in large numbers. I think only about 5% respond to it. Not because there's something wrong with the vaccine, it's because they can't, because their immune systems are blunted by the drugs they need to be on so they don't lose their transplant organ. So there has to be that option too, especially if you remove the mask mandate for the kids in the school.
Nurse Practitioner Ravindell.
I fully agree and support with every bit of scientific evidence that says masks are very important for this age group that cannot be vaccinated. However, I have spent my entire career, first as a teacher and now as a school-based healthcare clinician in schools, and I think it is still extremely important to look at what is reasonable and is and is able to be operationalized. So because of that, and because of what you had outlined for us at the beginning, giving the timelines and the MOU and the fact that there's very important deadlines in place, I do think that it is a reasonable, and I think another point that is important, it seems as though as it was written and as presented today, there does seem to be a level of direction and maybe authority coming from not just the board, but the superintendent as far as making those changes that may come up, further availability of vaccine or, further decreasing numbers, which of course we all want to see. I think what's been presented is very reasonable to make it an optional mask situation. Again, just because of really thinking about operationalizing a continued mandate it's daunting.
Okay. Is Dr. Mansfield still on the line with us?
Yes, I'm here. Can you hear me?
Yes. Do you want to
I really appreciate the way Dr. Hsu had stated it, in that the way that we are looking at things now are very relative because it's June 1st. And it's unfortunate that we have a timeline when it's incredible to see even week to week the sways that we've seen in our population. To Dr. Muzinski's point, I think our answer may be very different if we start moving in the wrong direction, although I think we're all very optimistic that if things continue and people increase their to vaccinate, that we would be continuing in a better direction. But with that in mind, and also to Nurse Ravindell's points, given what she has seen and shared with us over this past year, which is incredibly insightful, as well as the tremendous work Dr. Rodriguez has done. I think that the way that the school board has drafted the outline of having it as an opportunity for those who have the ability to be vaccinated, but to the point that we still have a large cohort that we all know are unable to be vaccinated, keeping masks in place for that age group until such time that we can vaccinate under 12 would seem reasonable. Now, whether you can operationalize that along age, I think certainly is the challenge that I would, I don't know if I could ask the school board to take.
Thank you, Dr. Mansfield. Dr. Ajay, I'm sorry. Dr. Ajay. Dr. Ajay, are you still with us?
I actually will. Anything there? The only thing that I would add, if it will give anyone of us boards.
Dr. Ajay, it's breaking up.
There's a good likelihood that probably. Can you hear me better now?
It was breaking up very badly.
Is it better now?
I think so.
Oh, sorry. Okay, I'll
That's
start
much
again.
better. Thank you.
So what I said is I agree with both the position with Dr. Mansfield and Dr. Shu's position. It makes complete sense to keep it in place for the 2 to 11-year-olds, the elementary kids for now, up until the point when vaccine becomes available, or if the data suggests that the virus isn't as significant an issue, obviously stop vaccinating. Sorry, we can stop. However, the good news is the good likelihood that between September there will be an emergency use authorization down.
It's breaking up again, Dr. Ajay.
Thank you.
Thank you. Member Lopez, you said you had 2 questions.
That's all. No, the second one is
the
a
second one?
recommendation.
Okay.
And we're not allowed.
Member Gallo.
Thank
Where
you.
did I'm sorry. Do I hear somebody speaking? We lost Member Gallo. She is the last person queued. Pardon me? Last lady from? Okay. Pardon me?
I have a question.
You have a question? All right, go ahead.
I know that this past school year that we were following closely the transmission in our schools and the number of quarantines and positive cases, and we were able to respond because of all the contact tracing. Will that continue going forward next year, the contact tracing with our schools and keeping that COVID dashboard up?
Madam Chair.
Yes.
So, Member Castor-Dental, it would be our intention to continue that. Actually, we would start with the new school year, with the start of the school year, and continue tracking and tracing. And Dr. Pino's office would be still responsible for the contact tracing.
Okay, thank you.
Thank you, Member Castor-Dental. Member Gallo.
Thank you. Am I on? Is it on? Yeah. Okay. I can't tell. Okay. I'm always fudging with this microphone. Usually the light comes on, the light's not coming
It's
on,
not
so
coming
it's
on,
confusing
no.
me. Thank you. So just a couple quick questions. Is there any way that we can get the data that Commissioner Corcoran cited in his recommendation? I mean, he has data, right? He cited the data. Is there any way we can get that data? Can we call the DOE and ask them for the actual data that he cited? Because that would be extremely helpful.
Dr. Jenkins.
Thank you, Madam Chair. Member Gallo, I am happy to ask.
Thank you. And then I'd be curious to know what the recommendation from the Department of Health is. I know that the governor's already came out and said that he didn't believe that we should have a mask mandate, that he has also seen some data that would suggest we don't need the mask mandate. So I would love to know, did that come from the Florida State Department of Health? Is that who's providing the data? Did that information flow down to Dr. Pino? And if so, can Dr. Pino provide us with the data that the governor is looking at when he's stating that we don't need a mask mandate as well?
Excellent question. Dr. Jenkins, we will try, right?
I am happy to ask.
Thank you. Okay. And then I know that we had just discussed kind of that number per 100,000 where it would get down so low that we wouldn't require a mask. So what is that sweet number? Is it 10? Is it 20 per 100K? Like what number under 100K would be acceptable even without a vaccination for those students that we could say masks are no longer needed?
Dr. Muszynski.
You can't say for certain, but you could say that the risk of transmission within the population is going to get really low. There's this value called the reproductive factor. I don't know if you've heard about it. That's if you have COVID, how many people are you potentially infecting overall as a global health picture, not just as one person, but anybody in general, mathematically, statistically, how many might you infect? And that number has been between 2 and 3 for a long time, which makes it a pretty contagious disease. And once that number falls below 1, meaning your chance of infecting someone is only half a person, which is silly when you think about one person. But when you look at the population, that means the virus isn't traveling anywhere. It's kind of stuck, and it's getting ready to go dormant. So this is a really important thing to try to figure out when that is occurring. And probably one of the best measures are, there's 2 things. Dr. Pino told us one, and that's the percent positivity rate of testing. Once that falls below 5%, you know you're in really good territory. And if it gets down to 3% statistically, you know that this pandemic, at least in our area or wherever that number is really down to really low risk. In fact, if you look at the policy lab I told you about from Children's Hospital Philadelphia, their data, if you look at some other expert COVID websites, as well as Johns Hopkins, there's a range, and the World Health Organization also has ranges, but the ranges I trust the most are from Policy Lab and from Johns Hopkins, because they've collated the most data on this, that if you're above 100 cases per 100,000, things are really bad for you. And you heard from Dr. Pino, at the height of everything, we were over 300, which makes it ridiculous to even have to even consider no masks in school at that level. That would be very dangerous for everybody. But now that the vaccine's here, that level has dropped way down, and you heard it's way below 100.
It's like, I think you said 40.7, is that
right,
correct?
And that is really great. It's not quite where you want it, because people say the sweet spot is under 20, and the mega sweet spot is anywhere between 5 and 10 people per 100,000. By then, it's just sort of a wispy little virus out there that you can easily control with more vaccination. And masking would probably not add much to prevention at that low level of disease in the community. So I hope that answers your question. These are parameters that can be used and have been recommended to be used. It was recommended to use these parameters for even the opening of schools, saying that if it was above 50 to 100, then you should consider delaying school openings and make it virtual, which we made it partially virtual at the beginning. Remember, virtual at the beginning, because that's where our numbers were. They were high. But we showed, though, and I'll just put in another plug for masks. We showed with the great work done by you all and working with us by masking, improving the ventilation in school and distancing, you really stopped that virus cold in most of your schools. It's impressive what you did. And now to take that all away when we're not quite at the sweet spot, I have an analogy I tell people, maybe you could visualize this too. Why is it so many Americans, when they're playing that big game and they're running down the field with that football and they see the goal line to score a touchdown to win the game, that they get so excited that they spike the ball at the 1 yard line? You know, we're not at the goal line yet. We're very close. We're at the 1 yard line. And time will tell whether or not we cross that goal, probably this summer and into the fall. And I got my fingers crossed, and I'm hopeful and optimistic we're going to get there. And like I told you, if we get way down to 5 cases per 100,000 in this county, I'm going to tell you, okay, masks are optional. Now I'm not going to tell you that.
Member Geller.
Okay. So, so I think Dr. Pino had said that we've been below 5% since 5/22. Do we expect that will continue to go down this summer? And is it possible for us to get to that 3% prior to school starting?
Well, under 5% is really the goal. 3% is really ideal.
Okay.
So we're in a great position right now. Now, whether that holds or not is another story. And like I keep trying to tell people, this pandemic is in the United States is barely something like 16 months old, and that's not a lot of time to really figure out where things are truly going. You can see trends and such, but predicting it is really hard. But everything we know about these vaccines, and I'm going to tell you that our vaccination rates in the United States and even in Florida are getting high enough where we're making a big effect on this virus's ability to infect people. And if you add to that the immunity that's already been acquired, which a lot of epidemiologists don't like to do, they're old school epidemiologists, they don't add this because we can't say for sure about the actual disease, how good it is with immunity. But I think it's good enough that you can add it to the vaccinated people where we're really close to that threshold of herd immunity. We're getting there. And it's going to happen soon. And they're projecting that, what they say, 70% of Americans will be vaccinated by midsummer. That would be incredible. And at the current trends, increasing. So it hasn't fallen flat. It's still increasing, number of Americans getting vaccinated. So we just got to keep that increase going and get over that 70% threshold. And I think we'll be a long way to just making masks mandated a moot point and not a contentious argument like it is now. So medically, the best thing is to continue the masks, and maybe it'll be moot by the time the fall rolls around. I pray it is.
Dr. Hsu.
Yeah, I also agree with Dr. Minsky. I'm very hopeful and optimistic we can get there. We do need the vaccinations to continue to be in full swing at the current rate, if not better. There are also other factors that we can't predict. Variants, for example, could be into play. But again, overall, if you say can we get to that number, I would like to think so, and I think that we really possibly can. We just keep our fingers crossed and continue doing what we're doing.
Okay, thank you. Thank you so much for everything that you've done for us and guiding us. It's so appreciated. Just thank you.
All
right, thank you, Member Gallo.
I want to make one quick comment about variants. The other optimistic thing, Dr. Hsu, is we now know that like Pfizer vaccine at least is effective against even the variant that's coming out of India. And in preventing disease and preventing badness, like going to the hospital and dying. So I am really optimistic that if we keep in the United States vaccinated, we're going to be safer than the rest of the world. The problem is when you have places like where it's exploding in India, that's a hotbed for variants to arise. And until they get their thing under control, the worldwide picture is not going to be predictable. But here in the United States, we can make a big difference by our great technology that we have, our great health care systems that we have to vaccinate our people and protect them to our best of our ability.
All right, thank you. All right, no further questions from board members. Member Lopez.
I'm sorry.
That's
The
all right.
last one, I promise. I think this is for the superintendent. I highly appreciate all the recommendations from the Medical Advisory Committee. But in previous year, we always use surveys. We do it for opening schools. We use it for start times. I don't know if we can do it as well for this mask policy. I would like to know more feedback on this matter.
Member Lopez, I will give you my feedback on
Yes,
this.
no problem.
because I've thought about it a lot, and as much as I appreciate democracy, I also believe that we have a representative form of government for a very important reason, and that decisions that are based on science don't come down to popular opinion. So I am not comfortable, as much as I would like to know what people think and how they feel on this subject. I think that we are called to do what we believe is in the best interests of our students, our faculties, and our families, rather than what the average person would prefer. And it's not because I think the average person, I'm no different than the average person, but when you take this position on, you spend a lot of time researching and understanding and weighing the pros and cons, and I think we were elected to do that. And again, on things that come down to opinion, I think getting people's opinion is important. But when it comes down to science and health, I think that unless I'm not comfortable with making this decision that way. But I'm one person, and I'm just one person. So I
agree with you 100%.
Okay.
I agree
Okay.
that we
Okay.
have to be focused on
Okay.
that advice. So I just want to ask to see if we can have the same options of like we used to have for other
and you know,
situations.
as much as and I very much appreciate MAC, but I mean, it's not just MAC. To me, it's the CDC. It's a whole host of sources of information, and I'm sure you all have done. I mean, I've gone back and looked at the pandemic of 1918 and what they learned and believed about masks, and the whole issue of studies that were initially done on masks that looked like maybe they weren't really effective, but they were comparing one jurisdiction to another that was at a different rate of spread, and they were comparing the results, which was, you know, scientifically invalid. So I think at the end of the day, I think we have to make that decision separate from what people think or want. But again, I'm one person. I will, if other board members want to jump in on that, if they don't, I'm going to assume that we're comfortable with that. Dr. Kadia, and then I'll go to Dr. Jenkins.
I just wanted to add one other thing not on that, and it's something that Dr. Musinski brought up earlier on, and I wanted to point out too. It's bullying, which it appears from what we're seeing that when it's optional use and it's not uniform, those children are facing bullying. So I do think that's something important to take into account. We are worried about mental health. Bringing kids back is the goal. But putting a letter A or whatever it is that we're doing on those that for whatever reason are still using the mask, I think it's something else that needs to be thought about.
Thank you, Dr. Kadia. Actually, some of what we've heard from parents that are opposed to masks is that their children have been bullied because they're not wearing the mask correctly. And, you know, my thought on that was, it would probably be good to teach your kids how to wear the mask correctly. I never support bullying, obviously, but I do value your thought on that. And I will tell you that one of the things that I struggle with in this decision is the feasibility of optional working and the dynamic in the classroom of those who choose to and those who don't. When I see the dynamic in our community on this issue and the amount of anger that is generated over this issue, I do get a little concerned about what happens in our schools when we haven't stepped in and just taken the responsibility to make a decision on that. So very good points. This is really not an easy decision for this board. I know that. I appreciate board members ask so many questions and what they often do. And I always know collectively we will ask all the questions. But what you heard was like email after email after email that I've been getting and you've been getting, and making sure that those citizens that have asked us these questions, that if they want to watch, they've had an opportunity to hear your answers to that as well. So this board takes their responsibility very, very seriously. And I know you all have as well. I mean, we could not have asked for more commitment, more dedication to our students, their welfare, and again, the community's welfare, our teachers, our faculty, our staff. So thank you so much. I have a little personal gift for you guys, just a little sweet gift for you before you leave. Dr. Jenkins.
Madam Chair, if I can just review just for members of the board timeline so everyone is clear. There really are two different pathways. One, and I was consulting with your parliamentarian/general counsel to make sure I was clear on that. So the timeline that we have currently says that we are going to have this same draft for further public input on June 17th. After that public input, the board would make a determination either to amend the policy and push back or move toward final adoption and a final public hearing on July 13th. If the board decided, which I probably wouldn't recommend on the fly, to try to amend the policy today, you would still have to push back rule development to June 23rd and then the final adoption again on July 20th. We have time, if you, after hearing further public input, to make amendments to your current advertised policy. But I wanted to be very clear, make sure folks understood. If you tried to amend it today, you'd have to get the language straight, advertise tomorrow, and push back your rule development workshop. I recommend you leave it as is, take actual public input, and then you can make amendments at that point and move forward.
So Dr. Jenkins, what I anticipate after listening to this, and there may be other permeations of this, but I would anticipate Member Cobert's language included in there, whether we say medically recommended, but some sort of a statement of, you know, we encourage you to consider something along those lines, the benefits and whatnot. I think there's a good chance we'll want to add that. I think the other possibilities, and I wasn't sure if we could advertise all of this, but we've already advertised. So if we change anything now, it would slow us down. But I think there's a possibility that we would go with optional or not optional. I think there's a possibility that we would go with K through 5, mask based on what we heard, and not all of our schools. Those are some of the permutations I think will probably get debated at the next meeting. Anybody have any other permutations and I'm just going off of the recommendations we've heard in the feedback. Member Gallo.
Thank you, Madam Chair. So I understand what you're saying, and I just asked our Deputy General Counsel if we added the word medical, would it substantially change the scope of the policy? And I was told yes. So thank you for that. I'm in agreement with Dr. Jenkins. I think that we've kind of put out a plan. We've got people set on the 17th. If we're going to make any amendments, we may want to further amend it after we hear comments from the public. And so I think any changes should take place there. If there are any, we may come to the conclusion that maybe that this is the policy is good as written after we listen to everybody. So I would recommend that we just hold the course for now, have the meeting on the June 17th, and then if we need to amend it and alter the schedule, do so at that time.
Yeah, I am in agreement with that. I did, for the benefit while we're doing this publicly, it would be easier for staff to know, to be able to come rather than us. If we make a change here or there, to be doing it on the fly is always very difficult. So I think that that language that Linda suggested would be helpful for y'all to work through, and perhaps to consider some of those other possible options for the board should they go in a different direction than straight down the line with that. Dr. Jenkins.
I'm so sorry I didn't finish what I was going to comment on earlier. So with Member Cobert's language, happy to have that drafted and available to you. I would submit, this is the other thing I was talking to your general counsel about, I would submit terminology around a recommendation might need to be a separate statement from policy, because policy in general doesn't usually say we recommend something. You can have a co-authored or a co-sponsored statement that says we also recommend, because the policy usually says yes or no, do it or don't do it. So the recommendation, it seems like it might fit better in a separate statement than the actual policy, and we'd be happy to draft that as a possibility for you as well.
Okay. Any other thoughts before we adjourn this meeting? Member Gallo.
I'm curious as to when on June 17th, we're anticipating a rather large crowd. So I would like to know what capacity we're going to allow in the boardroom. What are our plans? We want to ensure that we hear from everybody. It is a rulemaking. We will hear from everybody. Because I've received emails that they were upset that we weren't able to get to everybody, but they didn't understand the process of our rules for the pre-agenda, that they weren't speaking to an agenda item. We will be taking everybody that wishes to speak on the 17th. So I was just curious if we could go over the capacity that we will allow in this room and what our plans are so that everybody understands they will be heard.
Dr. Jenkins, great questions.
Yeah, we do have plans. The seating arrangement you can see by the banners that are on the back of the seats here. There's seating in the lobby area, and we'll have overflow available in the cafeteria as well.
And if we run out of seating there, just hypothetically, people will have their cars. And my next suggestion would be the people that don't fit anywhere fit in their cars, and then we start cycling people through as the chambers.
After folks have spoken, then they can.
Yeah, they can leave, and we'll bring in the next round. So, but thank you. That's an excellent question.
Just what is our current capacity in the boardroom? Because I don't know. I'm curious too. All right. Thank you.
All right. Other questions or comments? Excellent recommendation that we get that worked out. I think I got the same email. All right. With that, I dare say this. Oh, let me mention one more time, real for the record, Dr. Jenkins. The upcoming dates are June 17th for our rule development workshop and July 13th for final vote. That is tentative if there aren't any changes to the policy. All right. Thank you all so much. God bless. Meeting adjourned. Don't run out till I bring you something.